All right, so next we're just going to go through some of our grants. So these are our grants that we have recently applied for and kind of where their status is. So we did get one funded out of this list. So the Shadyside Hospital Foundation, and this was a grant that Christy had submitted before she left, and it was really, the goal was to secure funding for that position. Unfortunately, we were notified about the award after she had already left, but so we're trying to look to fill that position and have a UPMC kind of focus coordinator in that role. The other ones, we have submitted the Action for Women's Health, which was through Melinda Gates funding opportunity. That has been submitted, and we've actually made it all the way to the last round. So right now we're just waiting on the edge of our seats to find out. We're supposed to find out around November on that, whether we get it or not. But we have had really favorable feedback through all the steps of that. We also have submitted a PCORI recently, a letter of intent. Unfortunately, we were not selected to move forward. We're kind of reevaluating and deciding whether we want to resubmit that. Similar to the Shadyside Hospital Foundation, we submitted for the McKeesport Hospital Foundation. We did not receive that. We submitted for a craft prize with really a focus on partnering with our Southern provider in Mississippi and a researcher at UMass. We also submitted, there was a new opportunity with the Pennsylvania Department of Health as our grant ended. We did submit to that as well. Unfortunately, we did not get funded with that. And then we partnered with UNC to submit for a fourth trimester proposal. And finally, the Sentient Corporation, we submitted there for expansion in the Midwest. But here are our current grants. So the first one on there is listed, but that did end June 2025. So that was a 5-year grant. We'll go a little bit more into that towards the end, but we're completing the final grant report for that. We do have a HRSA State Maternal Health Innovation Grant where we are in partnership with the Pennsylvania Department of Health and the Jewish Healthcare Foundation, and working with them to kind of understand what the priorities in Pennsylvania are and how we can utilize the IMPLICIT model to really help address these priority areas in areas that may be maternal health deserts. We also have the ABFM Foundation grant, which is our focus for that is implementing new sites in Minnesota and Tennessee. So that's currently happening. And then our newest grant is the Philadelphia City grant, which Emily a week before decided to apply for it, and we got it, which was amazing. So that's really helping our concentrated focus in expanding to sites in Philadelphia, because currently Penn Family Care is our only Philadelphia site, and we've been trying desperately to get new ones there, and we have a lot of sites that are moving forward with joining the network through that. Potential grants, just to keep everyone updated. So we are looking at potentially submitting to the W.F. Kellogg Foundation. We're trying to figure out, we've submitted to it before, but with a more regional focus, and we're looking to submit to it on a more national level. The one that's kind of the most upfront right now is the CareSource Foundation, which we're interested in submitting to that to create a similar thing that happened in Pennsylvania with our PADOH grant, to create an Ohio consortium. And we have our Metro Health site is already a site, and then we would hope that Cleveland Clinic would be a potential new site for that, and then also looking to Ohio State. And then Bill Gates recently announced that he is going to have a $2.5 billion commitment to research and development in women's health. So we're just keeping an eye on those announcements. If you ever hear of a grant opportunity and think it would be something that would be beneficial to our network, please reach out, let us know. I think it's, especially in this landscape, we are willing to apply for lots of different funding sources to help support our network, and especially our staff, because our staff is really what helps continue moving the network forward. So I want to congratulate Hunterdon Family Medicine Residency that they began sharing data this January 2025. And I'll let her introduce herself. How long you've been with the network? So it goes to show sometimes it's the long game that, sharing data isn't always immediate, but it can happen. But also just wanted to highlight their initial data, which is from June 2024 to March 2025. And they have some very good looking rates of screening. So we like to see that and definitely appreciate all the work you did to reach that milestone. Yeah. Absolutely. And having Mike and Amy definitely is helpful too with our epic builds. And so it's a team effort. And then we'll change it. Yeah, so it is an example of a site that does not use Epic, how they were able to make it possible, because I know we have some sites without Epic, and it is definitely more challenging, but we have ways of making it work. So finally, I want to look at our website. So you should have received an email that we have our new website launched. We're very excited about this. This has been something we've been talking about for several years now. So just to briefly go through it, you obviously have your home about, which kind of is more the history of Implicit, where we work in our team, and then you can go into the projects, which focus on ICC fourth trimester, but also our committees and what's happening there. We do have resources here. These resources are more kind of public facing resources. So some of our webinars, our network guides, our ICC toolkit is here. Some of our information on what we're screening and why we're screening, and then also scholarly articles are also there. If you're looking for specific resources for workflows and data builds and IT support and IRBs, we have this new membership resource that you can click on, and you would register for it. So any of our current members can register for it. And then you would be able to access those resources. So the goal of this is, historically, we've been using Google Drive for this. We know since COVID, all health systems have blocked Google Drive, so none of the providers can access it. So this is our goal, to really create a space where if you're looking for resources, you have those resources available at your fingertips. So I just wanted to share, to show you what this would look like. Once you, it will not look like this. Sorry. Let's see if I can go. Okay. So once you log in, you'll have the resources, and then again, it's split into kind of the general implicit with participation agreement, membership guide, and then our scholarly activity link, which we're asking people that if you are submitting any scholarly work, you fill this out quickly. This is really just to help us keep track of the work that's happening and making sure we can be able to highlight it as well. And then resources for ICC and fourth trimester. So different sites, workflows. We also have IRB examples. So this is a portion we're still building out, and we'll definitely have more resources. But please register and join this. I will, once you register, if you don't get login information right away, please send me an email, because I just have to approve them when they come in. And please share the website with others. All right, so centering on our network current projects. So obviously we've talked about the website that's launched. We're still we're still adding some stuff to the membership section, and we're also testing out having event registration through that so that it wouldn't just be a email invite, that you would be able to register and have a more formal calendar invite that comes through. So that will either come with our spring meeting or one of our next webinars. We also are beginning work on a fourth trimester toolkit. So we have a couple of sections completed, and then we're finalizing the outlines for the other sections and assigning sections and setting deadlines. So our goal is to kind of mirror this similar to ICC toolkit, but obviously it's a little bit more complex because we have a lot more things we screen for in fourth trimester compared to ICC. Webinars, we do have new topics set, and we're working right now to secure presenters for them. Once we get the presenters secured, we're going to be applying for CME credit, and setting dates for those webinars. So look out for those. If you have any topics that you're interested in seeing covered, or people that you think would be good to present topics, please let us know. Our new PDSA cycle will be launched at this meeting. You'll hear more about that later. And then we have our fourth trimester outcomes publication is in the final month of completing chart reviews, and then we'll start analysis and writing up the results and discussion, and then submitting that for publication. We also are working with our HRSA grant on our HRSA evaluation portion. So that will give more information, but our Pennsylvania site providers will be surveyed and interviewed for that to hopefully better understand what parts of our implicit network work well, what could be improved, and then also what that additional funding in Pennsylvania, how that really helps support those sites, and how we could potentially leverage that in other states. So I just wanted to highlight some potential new sites. So obviously with our Philadelphia City grant, we have multiple sites through that. We have 3 sites that are right now, their site buy-in meeting has completed and are working towards onboarding and implementation. So that's amazing. And then we have 2 sites that we're still working to have a buy-in meeting with. We talked about Cleveland Clinic. Dr. Myers, who was at Metro Health as a site champion there, is now at Cleveland Clinic and is interested in helping them join the network. So excited to see where that goes. We have also met with California with the Department of Health there, and they have a Transforming Maternal Health grant that they're exploring how to spend the funds through that, and have talked to us about potentially having Implicit be part of that and implementing ICC and/or fourth trimester at sites. We've also met with the Indiana Department of Health. They came across our toolkit and reached out for more information. They're really interested in piloting Implicit at some local health departments and in community health spaces, so different than what we've done originally. So we're still working on what that could look like. Chicago, we had Anna, our provider champion, or she was at McKeesport, UPMC McKeesport, and has been working on our fourth trimester outcomes paper with us and recently moved to Chicago. So once she gets settled, interested in helping her new site join the network. We love to spread our wings and have our people go to different places and be able to spread Implicit. And then we also had a MPH student from Chicago that made some initial connections with us that we're going to continue exploring and reaching out to different residency sites there. And then finally, our most recent one, Florida, we had a resident who attended an AAFP presentation where Implicit was presented during it and reached out, and we've had an introductory meeting, and they are bringing that information back to their residency director to determine buy-in and feasibility of them joining the network. Finally, I think something that as we continue to grow the network, we really want to emphasize and bring to the attention of new sites and also our current sites that with the ACGME has been having a recommendation for program requirements for family medicine residencies to be part of a learning collaborative. And the Implicit Network fits that. We are a learning collaborative. We have it already established. And really trying to leverage that as a way to bring in new potential sites. So some committee updates. So the data review committee, our current projects, we've been supporting the start of the PDSA cycle, also supporting our current scholarly publications, our fourth trimester toolkit, and Amy has been working on doing a fourth trimester epic build similar to what we have for ICC, so that new sites starting to do fourth trimester, if they have epic, they would be able to utilize a build that's already there and not have to create something from scratch. We're also working on outlining scholarly participation guidelines for sites. Continuous work, we're always supporting quality improvement projects, troubleshooting data issues, evaluating the R reports with ICC in fourth trimester and deciding if things need to be updated. We are looking at a potential new project, just reevaluating our multivitamin risk and intervention in ICC, and just looking at if there's something we can do better with that. We recently supported the fourth trimester update and phase 2 rollout. And then we meet every Tuesday. That's a Wednesday. Sorry. It's supposed to be a Tuesday. So our next meeting is October 14th, and you do not have to be a data person to attend this meeting. You also do not, attending one meeting does not mean that you have to attend every other meeting. It's a great place to really talk about ideas and talk about how we could look at data differently, and ask Mike questions and have that space. So we really encourage people, if interested, to attend. So Health Equity Committee, some current projects we've been working on, and we'll go further into detail about this with the breakout session, but really bringing in the birthing person's perspective on dyadic care and what we're doing within the network, working towards creating a patient advisory board and a community advisory board so that we can bring that patient experience and voice into our network better. We're also exploring some legislative collaboration with the March of Dimes in Pennsylvania, and also recently met with someone who's trying to move forward a legislative bill in Massachusetts. Supporting social media content and helping sites connect with community resources. Recently completed projects, we did the mission, vision, values, reaffirmation just in the current climate. And drafted a legislative support base letter. So if anyone's, interested in doing any work with that and would like to have a letter of support from the Implicit Network, we have that coming. So the next meeting that date is still working on being set, but that will be coming in mid-October.
Great. Hi, everyone. I'm going to kind of take over and talk a bit about scholarly work within the network. So I'm leading the Scholarly Activity Committee, really trying to promote more scholarly work within the network, whether that be presentations, publications, posters. This year, we've had a pretty good presence at some conferences. We've had 12 presentations overall, combination of presentations and posters at 8 different conferences. We do have some going on this weekend. The yellow forms or paperwork on your tables that has anything that's in the Implicit network, so any providers in the network that are doing presentations, and we've starred the ones that are Implicit specific. We had one publication this year, Brianna Moyer, her narrative piece was published. You can find the link for that on our website as well. So very excited about that. We had one publication submission, which I'll talk a little bit about more too in the next slide. We have 4 current projects that are working towards publication. The main focus that we've been doing for our Scholarly Activity Committee so far has been doing better tracking of what we're doing as a network. So what projects we're working on, what, how many presentations, how many publications. A big focus is we're really trying to move some of these projects more from presentations and posters to a publication. Tracking wise, also, we mentioned before, if you're doing any scholarly work, just fill out that form. You can find it on our website. I also send out an email monthly with the form in it, as well as some dates for upcoming deadlines for conferences. If you are presenting at a conference, we also are trying to feature everyone on our social media, our website more. If you're comfortable with that, you can always send me a picture if I don't reach out to you first. And then we're doing some more work on our research priorities and our network scholarly focus, which I'll talk about a little bit as well. Our meetings are open for everyone to attend. So if you're interested, our next meeting is next week, Wednesday, September 24th, and we'll kind of debrief a little bit more about what we're talking about here today. All right, so this is a snapshot of the projects that we've been working on as a network over the past year or so. So the 4 trimester outcomes, we talked about that a little bit more. We're kind of in the process of finishing up some of that chart review, then analyzing that data, plan for publication. We did submit an abstract to ACOG, so waiting to hear on that. We did have a 4th trimester implementation paper that was submitted to the Journal of Family Practice, so still waiting to hear about that. Contraception behavior change, which Napora has been working on. That's in the early stages. Kanza, who's here today from LGH, has been working on a multivitamin QI project, which we'll actually get to hear a little bit more about later today as well. Network QI, I'll talk a little bit more about the PDSA cycle that we have ongoing. We're also presenting tomorrow at 9 a.m. About how we do quality improvement as multi-site learning collaborative, if anybody's interested in going to that. And then the qualitative 4th trimester project that was presented last year is working to recode some interviews and analyze that data, preparing for a publication for that as well. And then just highlighting again that we had that one publication. And then just real quick too, the 4th trimester toolkit. So this is an overview of what we're planning to include in the toolkit. So the goal overall is to provide some background evidence and resources to implement the 4th trimester model. We're really modeling off the ICC toolkit, but making a 4th trimester version. So if you're interested in looking at what that ICC toolkit looks like and what we're kind of hoping for that 4th trimester, we have 2 copies over on the side, so you're welcome to kind of like flip through those. And so far we've completed the literature review in the background section, as well as kind of the model aims and goals. The rest of the workflow, data implementation, billing, barriers and lessons learned, we'll do some case studies, and then we're working with the 4th trimester project that's based in North Carolina to create a patient-facing section as well. So we do have a team that is working on this, but if anybody else is interested in providing any recommendations or helping review and edit, just please see me. You can see me today or shoot me an email. But that's the update on the toolkit. All right. So now I'm going to shift a little bit more into talking about what our scholarly focus and what we're hoping to achieve through the committee and the network, really just kind of promoting more of the work that we're doing and getting more of our work out there. So the goals of our committee are to promote broad and equitable scholarly work and participation across the network. So often when we meet at Scholarly Activity, it's usually kind of the same group of people. So we're really, which we love, but we're really hoping to kind of get more people from other areas. We know that people are doing projects at some of their sites, and we really want to know, what you're doing, how we can help, move your projects forward, and if you're interested in publication. Another thing that I'm kind of hoping to do a bit more with some of our scholarly activity meetings is to have people who are presenting projects at conferences present to our scholarly activity committee as well, just so that we know what you're doing and we can kind of talk with you a little bit more and see what your thoughts are for the project. Again, that goal is to move some more projects from posters and presentations to publications, providing some more scholarly scholarly activity opportunities for residents and faculty, and just guide the overall focus for what our network scholarly projects are going to be. So this we created earlier this year. I think we might have presented this at the spring meeting, but just kind of want to refresh again. We do have a scholarly activity master log now. This has all of our network scholarly projects from as far back as 2008 to the present. So it's a kind of living list of everything. It constantly gets updated, as well as a research priority list. That research priority list is an old list of project ideas that we're really hoping to revamp and add to, which we'll kind of get to today. So just to show you how this works. So I'm going to exit the view. So if you just look at it regularly, it's just kind of ordered chronologically. There is a key on the first page. So anything in green is a published paper, the orange is an oral presentation, and the red is a poster. And you can sort by year, ICC or fourth trimester, risk factor or topic, cite the type of scholarly work it was, what conference, so where it was presented, or publication where it was published. And the way you can do that is just click this little thing right here, and you can sort. So let's sort by risk factor. So it would have sorted anything that was a breastfeeding. This one was breastfeeding family planning, any depression work we've done. So you can sort it that way, or, you know, let's say you wanted to look at it by what conference it was presented at. So obviously we have a very strong presence at FMEC, so we have a lot of those here, but we have presented at things like APHA, AAP, AAFP. So this is a living kind of document. That's why also it's, you know, just important that we really want to get that scholarly activity form filled out as well, so that we know what people are working on. This, I can move this around. No. There we go. So this research priority list is something that we're working on. This is not a finished copy, but this has an old list of some research priorities that we were working on as a network. So we're kind of going to revamp that today, which will be the focus of our breakout session. So these are 5 topics that we've talked about either in the Scholarly Activity Committee or with our Leadership Council that we've kind of identified as potential research topics for the network. So we've so far brainstormed comparative effectiveness of ICC interventions, cardiovascular health and chronic conditions, mental health, demographics or health equity focus, which really could be applied to whatever topic we deem that we want to look at, and then postpartum care engagement. And I've listed here kind of the data that we would probably look at for each one of those topics. So thinking about that, we will then move into our breakout session. So thinking about everything that we've just discussed, thinking about how we really want to move some more projects from presentations to publications. What are our network priorities? So thinking about those topic areas, you'll find a form on your table that has the scholarly activity breakout focus instructions. It'll have each one of those topics lined out there for you as well as the questions. So for 20 minutes, we'll have you discuss those topic areas and think about, what may a research question look like for each one of those topics. This is, I think, outdated because we're just going to have you, it should say on the form that we're just going to have you kind of rate 1 through 5 what you think are the most important topics to focus on, and then think about what is not on that list that maybe should be, and how, if you have any time, how might we turn some of those presentations or posters into publications. So, you'll talk amongst yourselves in those groups at the tables that you're at. Never mind. We're gonna, I think, switch you guys up a little bit. And we'll have 45 minutes for our breakout session total, but we are gonna switch halfway through to talk about health equity. So we'll spend 20 minutes on scholarly activity.
Oh, thanks everyone. I apologize that I'm not there in person. They leave the statistician behind sometimes, and this is where I am. So my task is to, as I usually do at meetings, is to just present some slices of our data that we've collected as a network and highlight some specific questions that were given to me by the data committee. And so my focus will actually be both on ICC and fourth trimester. We're going to take a look specifically at some screening risk and intervention rates over time that we've collected during the period of January 2020 through August of 2025. So we're going to be kind of looking at what's been happening to those rates over time and kind of assessing the variability, from that month-to-month metrics that we track in the network. And then in the fourth trimester data, we're going to be specifically looking at the timing of the earliest postpartum visit and kind of looking at that across a couple different categories in terms of risk as well as race and ethnicity. And particularly there, I was asked to look at, is there anything that kind of stands out and kind of at least present some data that might lead to some potential publications. So before I get into the actual data, I just wanted to quickly cover a little bit of an overview of two methods that I will be using to display the data and just provide some context for how to interpret what's presented. And so for the rates over time in the ICC data, we'll be using what are called control charts, or sometimes they're called SPC charts. And these are essentially tools that help us better understand variability of data over time. Anything we measure, that whether it's screen rates, risk rates, anything that we measure over time, there's going to be variation. Things are going to bounce. It's never going to be the same month to month. And so a lot of the challenge, the statistical challenge, is how much of that variation is what we kind of call normal. And that, if it's just a stable process over time, you're just going to kind of see some bouncing, month to month variation. But if something is changing or has changed, then we typically start to see some patterns. And so, if we see those patterns, what does that tell us? As this sample graph over here, you kind of see this pattern in a certain time period, and that indicates that something may have happened over that particular window. And so a lot of what we do is just kind of teasing out what's normal and what is kind of non-normal or a non-stable process. There are, if you look at the literature around control charts, SPC charts, there are a ton of different I guess patterns or different types of things that folks look for to distinguish these statistical patterns that indicate something has happened. And I just listed a couple here that are commonly used. But again, there's not always a right answer, but there are a number of these different patterns that we look for, and we'll be specifically cueing in on some of those. In our current reports that we provide for sites or the network, there are some what are called run charts provided, and this is an example of one looking at depression risk in ICC. The hard thing is when I have these in the report blown out so that you see the full scale of 0 to 100%. And when you do that, it tends to hide some of the variability. It kind of looks, you see a little bit of bouncing around there, but it's sometimes hard to tell what's actually happening. The chart on the right is the exact same data, but we've magnified the axis. So this here ranges from like 4 to 12%. As opposed to 0 to 100%, and you start to see much more resolution in terms of what's actually happening to our depression risk rates over time from the ICC screens that we're doing. So again, these control charts are not something that are in the standard R reports that we provide. This was something I created specifically for this meeting. The second method I'll be using in the fourth trimester data is what's called a time to event curve or a Kaplan-Meier curve. I'm sure many of you are familiar with these. These are used in research studies that are time to event. Survival data is another common use where they are kind of a rich way to be able to display what's happening to a process over time. And so on the horizontal axis here, we essentially have the time from birth until the earliest postpartum visit. And so each one of these ticks is essentially a week. And the curve is showing us as an example here. So if we look, zoom in on week 1, we can see that approximately 12 or percent of our mothers or birthing persons had a postpartum visit. Their earliest postpartum visit occurred at kind of by that 1 week interval. And then if we jump out here to week 2, and again, if we extrapolate a line over here, approximately 30% of our mothers or birthing persons had a postpartum visit by that 2nd week, the earliest visit. So the Kaplan-Meier curve kind of gives you that visual representation of the cumulative proportion of individuals that we're tracking, how many of them, what proportion of them have had a postpartum visit by that particular time point. And then you see the line caps out here, it kind of stabilizes. So approximately 50%, excuse me, 50% of our mothers or birthing persons have a recorded earliest postpartum visit by that 10th week in our data collection. The chart on the bottom is just the denominator, so that just tells you what the denominator is at each week. Obviously, as folks have those postpartum visits, they kind of fall out of the denominator as you calculate that curve, going out to the right. So, so the Kaplan-Meier curves are kind of a visual representation of that time to that earliest postpartum visit. Right now in the R report, we kind of categorize all of our postpartum visits into a less than 1 week, 1 to 3 weeks, greater than 3 weeks. So if you categorize it as an ordinal category versus the Kaplan-Meier, those are again just kind of 2 different ways you can kind of present the data. And I'm going to be using the Kaplan-Meier for what I present today. Okay, so let's jump into the ICC data. I know Anna sent out yesterday a summary. There were 3 documents, these slides, and then there are 2 reports that I custom created for this meeting, one for ICC, one for 4th trimester. So everything that's here in the slide, these are just excerpts from those reports that I created for the meeting here. So in terms of our ICC summary, we did restrict this to well child visits that occurred between January of 2020 through August of 2025. So anything that your site has contributed during that time window, and if you're an active site, you would have been included in these data. So in that report that was sent out, this is just kind of that table that summarizes all of the dyads that we have recorded for each site. So this data represents just a little over 24,000 unique dyads, and we use the term dyads in the report to represent that mother birthing person / child dyad that are kind of represented by ICC. So quite a large number of dyads that are being assessed here in terms of the data, which I think again speaks to all the hard work that you all provide on a regular basis in seeing these patients and screening and so on. So it's quite a nice number. Just summarizing our overall screening rates that are included in the report. And again, some of you have heard me say this before, but we calculate screening rates 2 different ways. The first way that we calculate it is based upon a denominator of the total number of well child visits. And so the table here on the right highlights the screening rate based upon that denominator of the total number of well-child visits, regardless of whether the mother birthing person was present at the visit or not. And so the last column in that table is the actual screening rate. And we define screening as whether all or partial ICC was done. So all ICC means simply I screened for all 4 of the risk factors. A partial ICC means I have data that says that I only screened for depression, but I didn't screen for smoking, contraception, or multivitamin. And so the screen rate is basically if you at least did one of them, that gets included in the numerator for that calculation. So as a network, if we look at all of our 91,000 well-child visits between January of 2020 through August of 2025, we have over 91,000 well-child visits represented in the network, and we are screening for ICC 70% of the time. So again, quite an accomplishment for the network. Then over on the other, the right-hand side, these are the screening rates based upon whether the mother birthing person was present at the visit. And if we look over here at the far right column, in instances where we have documentation of the mother birthing person being present, we're screening 86.2% of the time. And the reason we have a couple sites here that are you'll see some NA values included. We have a couple sites that due to the setup in their electronic health record and their screening processes, et cetera, they are not able to ascertain across all of their well-child visits whether the mother or birthing person is present at the visit. So if your site is not able to conclusively determine whether the mother or birthing person was present at the visit, in this report, I have them kind of blanked out as a non-applicable. So if I take those screen rates, both the well-child visit screen rate and the mother birthing person present screen rate, and I plot them using a control chart, this is what it looks like. And essentially what we see here is if we look strictly at our well-child visit screening rate, you'll see kind of a downward trend in the screening rates through kind of the pandemic period, January of 2020 through kind of the end of 2022. And then it seems like we kind of restabilize at a new rate down here, somewhere around 65%, kind of starting in early 2023 through the present. And so with these control charts, one of the things that you'll see is you'll see that a center line, and that little dashed line there, that's our overall screening rate that was on the previous slide that we saw for the well-child visits. We were screening about 70% of our well-child visits. So that center line is that average, or that the average across this entire time frame. The gray area represents essentially what are called control limits. So you can see the gray area, and that represents it's based on the sample size. Essentially each month, what's the denominator in terms of number of well-child visits? As the number of well-child visits goes down, those control limits gets wider. As the number of well-child visits gets larger, the control limits start to shrink. And so essentially what we're looking at here is we've got a number of points that are outside those control limits. And you can see there, it might be a little hard to see where you're at, but these points here are orange. And again, that suggests that those are what are called out of control points. And again, alert us to the fact that there's some sort of statistical pattern here beyond just normal variation over time. And it clearly suggests that our well-child visit screen rate has decreased over time and then has restabilized at kind of a lower rate in kind of that 2023 to 2025 timeframe. If I look at our screening rate, whether the mother birthing person was present or not, again, I do see kind of a downward trend here during the pandemic. And then, kind of this stabilization. It's not as pronounced in this particular rate. But again, it does seem like during the pandemic, our screening rates took a hit, even with the mother birthing person present at a well child visit. But it does seem like we certainly have stabilized after the pandemic in terms of our overall screening rates. If I look at some of these rates by our different risk areas, so we have smoking, depression, contraception, and multivitamin. And again, these are the last rows of the tables that are in that ICC report that was attached to the email that Anna sent out. And so as an example, for the purple column here, I'm highlighting the risk rates. So our smoking risk rate for this time frame was 11.6%. That just means of all of the visits, well child visits, were smoking with screen. So about 62,000 visits out of the 91,000 were screened for smoking. 7,200 were at risk, which is a rate of 11%. Depression, so we're screening about 7% depression positive. Overall, we're screening about 30% of contraception risk positive, and multivitamin is about 44, almost 45%. And then over in the light blue column, we have the intervention rates. So when a risk was identified, what proportion of the visits did we actually then provide an intervention? And so for the smoking, it was about 85%, 93% for depression, 65% for contraception, and 61% for multivitamin. Finally, the red column, which is not highlighted in any of the control charts, this calculation is based upon including in the denominator of the intervention rates any instance where there was no documentation of an intervention, either yes or no, an intervention was done or not done. So any instances where a risk was identified, but then it was missing in terms of whether an intervention was done or not, I add those into the denominator, and so the rates are lower because we're assuming, essentially this rate is assuming that missing means that an intervention was not done. And so you can see how much the intervention rates drop when we assume that the missing intervention information is not done. But those, I didn't include those in the control charts that I'm going to show you here in a second. So we'll just be focusing on the purple column and the blue column in terms of our risk and intervention rates. So in terms of our risk areas, smoking is the first one. Again, these control charts are just showing the screening rate specifically for smoking. Again, we see if we're looking at our well child visits as a denominator, we again see that downward trend in both of these during the pandemic period, and then kind of a stabilization of our screening for smoking once we kind of got beyond 2022 and the kind of the tail end of the pandemic time frame. But again, you can see, clear with these control charts, you can clearly see what that trend has done over time. If I look at the risk and intervention rates for smoking, generally the risk rate for smoking seems like it's been pretty stable. It looks like some of our most recent data, it dropped down a little bit, but again, that could be just simply because there are a couple sites that lag behind a little bit in reporting some of their data, but it's something certainly we'll need to keep a watch on. Our intervention rates for smoking, this was really interesting. It's kind of been a steady downward trend. So as a network, it seems like over time, it's been a pretty consistent downward trend in terms of providing or documenting an intervention for when smoking is identified as a risk. If we look specifically at depression, again, we see a very similar pattern. We see that downward trend in the screening for depression during the pandemic, and then kind of a restabilization at a lower rate. And then if we look at the denominator of just you know, the mother birthing persons present at the visit, we again see a very similar pattern, that downward trend, and then kind of a restabilization of our screening for depression as a network. If I look at the risk and intervention rates for depression, this is interesting. I think I remember highlighting this at one of the previous meetings. We definitely see a jump in our depression rates over the kind of the pandemic phase, and I think that correlates with a lot of other studies that have shown during that pandemic phase the increase in depression rates and so on. So we definitely see that pandemic effect in our risk rate for depression, and then kind of a restabilization at a you know, slightly lower rate post pandemic. Our intervention rates for depression have been pretty consistent. It hovers right, you know, in that 90 to 100% range. It does seem like a lot of wild bouncing around, but overall, our depression intervention rates are pretty consistent. Contraception, again, a very similar pattern in terms of our screening rates. We have the you know, the pandemic effect here, and then a restabilization. You know, kind of in both instances again. I'm not sure what happened down here, but this seems like an anomaly of why in the network in January, or kind of starting in early 2023 through 2024, we had kind of a drop in contraception screen during that time frame. But if I look at the risk and intervention rate, this was interesting. So we were kind of, our risk rate was right around here, and we definitely have seen an upward trend in the contraception risk rate, particularly over the last 2 years or so. I'm not sure what explains that, but certainly there's definitely an increasing risk rate in our contraception rates. In terms of the intervention rates, there was kind of a steep drop off of contraception interventions over the pandemic, and then we've kind of settled into a new rate here. If I actually zoom in, there actually seems to be a slightly upward trend here in terms of our intervention rates for contraception over the last 2 years or so. And then finally, for multivitamin, again, we see the downward trend in our screening rates during the pandemic, and then we kind of settle into a lower screening rate post-pandemic. Again, very similar pattern that we've seen to the other risk factors. And then if I look at the actual risk and intervention rate, the risk rate for multivitamin has been pretty constant. There really hasn't been much that I see in here that I would say is really, you know, a significant trend. And then for the intervention rates, we kind of had a drop off of multivitamin intervention rates during the pandemic phase, and then we kind of, you know, have restabilized, you know, post-pandemic. I included a slide in here that just kind of, you know, very high level kind of gives a summary of, you know, what I see as happening with all of these particular rates: a screening rate, the individual screen risk and intervention rates for smoking, depression, contraception, and multivitamin. But you know, I'm not going to go through all those in excruciating detail, but they're there just kind of as a summary for discussion. And I think, you know, particularly for me, you know, the impact of the pandemic on implicit screening risk and intervention rates, I think can't be I mean, it's certainly a very prominent effect that you see in our data when you use control charts and look at it over time. And I think it's an interesting discussion point and case study in terms of what happened, you know, in our clinics and in our across our network. And then I just to kind of close out the ICC phase before we flip to fourth trimester, I just kind of posed some questions here. Again, these are just more discussion questions or things to think about, you know, as a network and as you're brainstorming and, you know, working in small groups or whatever. You know, we certainly see this variation over time. Why is that? Obviously, we had the pandemic. You know, are there other external factors that could be explaining some of these trends that we're seeing in our screening, risk, or intervention rates? You know, every time we onboard new implicit sites, you know, obviously they might, you know, take a while to get ramped up in terms of screening, risk, or intervention assessment. So, you know, is there an impact of new sites coming on board in our data? Should we look at this differently? Is this a reasonable approach to try to, you know, assess what's happening over time, you know, across the network? And should we add, you know, some of these types of reporting mechanisms in our standard reports? So anyway, so just some questions to throw out in terms of thinking more about what we see in our rates, the screening, risk, and intervention rates across ICC. Switching gears a little bit to fourth trimester, excuse me. So again, there's a summary report that Anna sent out just in terms of kind of highlighting some of the data that I focused on for this meeting. And so this is just some demographic summaries from that report. And I included a summary here of all of our sites that are participating in fourth trimester that have contributed data that are part of this report. And for this particular report, we used all of the data, phase 1 and phase 2 of fourth trimester. And so there are 3,738 mothers birthing persons that are included in this data set. And then the graph on the right is just simply the age. So it breaks the age down in categories so you can kind of see demographically what that represents in terms of our mothers and birthing persons. I included a race ethnicity breakdown. Again, race and ethnicity is something that can be a check-all that apply option. And so you can have a mother birthing person represented in more than one category here. So just keep that in mind. And then we have a plot in the report that it can be a little confusing when you first look at it, but in any instance where we have a check all that apply option, this kind of shows you all of the possible combinations of that particular variable. And so for race and ethnicity, we have all of the options here, and then you can see anytime there is a dot with a line connected to it, that indicates a combination selection. So these are essentially the mothers and birthing persons that have selected both white and Hispanic as a race ethnicity category. So it allows us to kind of represent those multiple instances where you might have. So essentially there were 308 of our mothers birthing persons that selected both white and Hispanic as in terms of their race and ethnicity. Hospital delivery method, again, just kind of highlighting for those that are included in this data set. So about almost 70% spontaneous vaginal deliveries. And then you can see the breakdown of the other birth types that we track. They notice that the N here is smaller because we're missing, again, if we're missing data on some of these, the N gets smaller. But for those that we do have this recorded, about 70%, you know, spontaneous vaginal, 2% vaginal assist, planned cesarean section, about 19%, unplanned C-section, 9%, and so on. Biomedical risks, again, this is a from the prenatal screen. So there's a lot of missing data here. So we only have data on about 782 of these mother birthing persons. And again, this is a check all that apply option. So you can see, we can have mothers birthing persons that have selected more than one biomedical risk. But again, this is the overall bar chart showing the percentages of each one of those risks. And then over here on the right, you have kind of all of the combinations where you have a mother birthing person with more than one risk identified. And then finally, for each of these, I included another graph inset here. This just shows you how many of them had, no risks identified, and then what percentage of them had at least one risk identified. So we have about 40% of our mothers birthing persons have at least one risk identified out of the 782. We also collect biomedical risks in the postpartum period. You'll notice that the N here is much larger, so we do have more data from the postpartum collection. And again, same thing, the graph on the right here shows you the breakdown of all of the biomedical risks. Again, this is a check all that apply option. The graph on the right showing you all of the potential combinations of multiple selections of the biomedical risk. And again, in the postpartum period, it's about 38% had at least one risk identified as part of their postpartum screen. Intrapartum complications, again, same thing. It's a check all that apply option. Graph on the right shows you the breakdown of all of the potential selection options. We have the combinations represented here, and we have the graph over here. So we have about 51, almost 52% of the 1,300 that were screened, have that screening completed at the hospital phase, have at least one risk. And then the postpartum screen for intrapartum complications, again, same display of the data. And interestingly, for the intrapartum complications postpartum, it's only about 34% have at least one risk identified. And then before I get into some of the Kaplan-Meier curves, I have just some summary information relative to the earliest postpartum visit that we have on record for these mothers birthing persons. So this is just simply like a histogram showing when that, at what week that earliest postpartum visit occurred. And then this is the graph that I showed earlier, just kind of categorizes it into those 3 week, less than 1 week, less than or equal to 1 week, 1 to 3 weeks, greater than 3 weeks. And then those that had a well child visit recorded, but the weeks were missing. And then we have about 43% that said, we have no well child visit recorded for that particular mother or birthing person. So these are the Kaplan-Meier curves that were produced for the earliest postpartum visit. So if I include our entire denominator, 3,740, and flag, essentially when did that earliest postpartum visit occur, this is what the curve looks like. And again, you can see that we tend to peak out here about approximately 50% of our mothers birthing persons. We have by week 10, we have on record when that earliest postpartum visit occurred. If I restrict it to a smaller N, where we have record that a biomedical risk or intrapartum complication screen was done, it's about 1,600. So for those where we have some sort of screening that was done for the biomedical risk or intrapartum complication, you can see that for those individuals where that screen was done, we have almost about 75% of our mothers or birthing persons have a postpartum visit by week 10. So you can see the curve is very different there when we restrict our denominator to those who we were screened for those particular risks. So what I did is I took those biomedical risks and the intrapartum complications. So again, the biomedical risks are captured at the prenatal and postpartum phase. The intrapartum complications are captured at the hospital and postpartum phase. So I essentially took all of those risks and I kind of mashed them together. I combined them together to come up with this list that I highlighted there on the right. And I basically was saying, okay, what I'm looking for here is basically, is there some sort of screening done for one of these risks, and then lump them together into similar risk categories to say, hey, I'm trying to identify moms or birthing persons that are at higher risk because of one of these complications or biomedical risks. And so it's just basically kind of and I'm not saying this is the right way to do it. I just was trying to figure out, is there a simplified way that I can kind of lump these risks together and be able to try to identify individuals that might be at higher risk that we really want to see earlier, and make sure they have that postpartum follow-up for these particular risk factors. And so that's essentially what I'm going to show. I'm not going to show you all of the Kaplan-Meier curves that are in the report that I gave you, but I'll just highlight a couple of the ones that had larger denominators or more moms birthing persons that had these risk factors. And so the first one is preeclampsia with severe features. And what I want to highlight here is how these graphs are formatted. So we have the Kaplan-Meier curve, and it's split out into two groups. And so the purple represents those that were screened that did not have preeclampsia with severe features identified in those as a risk. The red represents those mothers birthing persons that had preeclampsia with severe features identified. And what you're looking for is there any separation in the curves? And one of the things I noticed right away was in this particular risk area, we see this separation right here about between weeks 1 and 2. And essentially what you see is the red curve is slightly higher than the blue or the purple curve. And the confidence interval is that shaded area around the curves. And there's kind of a gap between the confidence intervals that you can kind of see right here. And essentially what that suggests is perhaps with mothers birthing persons with preeclampsia, we're getting them in earlier than those without that risk, kind of in that 1 to 2 week window. It seems like we at least with individuals with that risk, it seems like during that 1 to 2 week window, we're getting a higher proportion of these individuals in for that first postpartum visit, which may be clinically what we want in this particular group of individuals. If I look at the risk category of hypertension or mild preeclampsia, what I notice here is there's really not a separation during that 1 to 2 week period. There is a separation of curves once you get up here. So it seems like once we get to, out to, approximately 3 weeks, those without hypertension or mild preeclampsia are tending, we have a higher proportion are having, their postpartum follow-up. You can definitely see that separation here. And so those with hypertension or mild preeclampsia, we're actually seeing a lower rate of them having, these postpartum visits, across these particular time windows. Gestational diabetes, these curves essentially overlap. That you can see the confidence intervals are contained within, each one of the curves. So it doesn't really seem, for those with gestational diabetes, it doesn't seem like we're getting them in any earlier, or essentially at the same time as those with that don't have gestational included as one of their risk factors. Obesity. So for obesity, we do, kind of once we get out beyond 2 weeks, there is a little bit of separation here between those with obesity. We're getting a higher proportion of them in for a postpartum visit, and a little bit earlier once you get kind of beyond 2 weeks. If we look at postpartum hemorrhage, again, there really doesn't seem to be any separation between the curves. Once you kind of get out to 4 to 5 weeks, there's a little bit here, but the sample size, you can see the confidence interval really starts to get wide for those with postpartum hemorrhage. There really doesn't seem to be much difference overall with these particular curves. If they identify that they had no risks at all, this one's a little confusing to understand, but essentially the red line here represents individuals that identified they had no risks at all, versus the purple line. These are folks that had essentially at least one risk identified. The curves are the same. There's a little bit of separation once you get out to the kind of that 2 to 3 week window here, that we are getting folks with no risks, to have a higher rate of overall postpartum visits than those with at least one risk identified, which is kind of opposite probably what you would expect. But again, it's not happening earlier. It's more at the latter phases of time from birth to the earliest postpartum visit. And then in terms of those that are missing, I did include the missing as well. So the folks here in the red, these are the folks that are we didn't have a screen. Essentially, they didn't have a risk screen, either intrapartum complication or biomedical risk. So there was no documentation of any screens being done for them. And you can see for those folks, a pretty big gap here in terms of getting that. If we don't screen somebody, there's a high likelihood that they're not going to have a postpartum visit, and certainly not an early postpartum visit. So again, it does seem like when we're missing data or don't complete the screens, it's highly likely that we're going to be missing some of that information, and they're less likely to have those postpartum follow-up visits. And then finally, I did separate it out by race and ethnicity. Again, I'm trying to just give some ideas of, for potential publications of how we could, start to talk about how, using our data to get it out in the peer review community. And I thought this was particularly interesting. Again, race and ethnicity, it's a check all that apply option. And so the red here is if they checked that they had white race and ethnicity, and then the purple is essentially white was not checked at all. So they could be Black and Hispanic, they could be Asian and Hispanic, but essentially the red represents white checked somewhere. And again, they could be white and Hispanic, then they would be in the red group. But again, if they had white at all, you can see there's a pretty big gap here where those that checked off white, they're getting in earlier, and we tend to have an overall higher rate of postpartum visits in that group compared with those that do not have white checked as one of the race and ethnicity categories. If we look at Black, so again, the red represents that they have Black checked as one of the options for race and ethnicity. And you can again see quite a big gap here between those that have Black checked off, a much lower rate of postpartum visits and later postpartum visits than those in the purple group that are individuals that do not have the Black option checked as part of race and ethnicity. So again, I think certainly something here that I think we could delve into and potentially look at in more depth. With Hispanic, So if a mother birthing person has Hispanic checked off, they're actually getting in earlier and have a higher rate overall of postpartum visits. So than those without Hispanic checked off. If they had an other, so other includes Asian, I think we have a couple other race and ethnic categories, and the ends are really small there. So this is just combines. So if they have any of those other categories checked, excuse me, you can see the red curve here is pretty close to the blue one. There are a few small gaps here. I don't know that they'd be statistically significant overall, but pretty similar when we look at the other versus those without any of those other race and ethnic categories checked. And then finally, if they're missing a race and ethnic category, so the red is the missing group. Again, fairly similar. There are some gaps here, but again, with that missing, we don't know what race and ethnicity they are. It could be a mixed group. It could be, you know, very heavily weighted towards one group or another. But again, just for completeness, presenting that data. So kind of a summary of the fourth trimester data. You know, generally, you know, that time to first postpartum visits are very similar, you know, for those that have the risk and those that do not. I did think, you know, that preeclampsia with severe features, it does look like there seems to be a little place in there where it seems like we're able to get postpartum visits earlier in that particular risk group. But again, you know, I did this as kind of a proof of concept or a pilot. You know, I think more discussion around how we classify risk, you know, given that we do biomedical risk, intrapartum complication risk, symptoms since delivery. There could be a lot of things that we could do with some of the risk data to try to figure out like who are these mothers birthing persons that we really want or need to get in for these early postpartum visits, and then be able to compare them using you know, survival analysis, Cox regression, you know, Kaplan-Meier curves or whatever could be a way that we could look at some of that data. And then I think too, just highlighting the differences, the disparities across some of our subgroups in terms of our demographics, you know, that could be another avenue to explore just in terms of, you know, perhaps maternal age or, you know, these race and ethnic categories would be other areas that we could explore and say, hey, you know, what are we seeing in terms of getting across the network in terms of getting these mothers birthing persons in for their you know, the early postpartum visits. And then just again, more discussion questions again around fourth trimester. Should we, you know, explore this time to event methodology as an approach to assess the timing? You know, again, as I mentioned before, what demographics or how should we classify risk factors to include to be able to assess, are we getting these individuals in for timely and appropriate follow-up as part of their postpartum care? And then we do have missing data. That's the nature of our implicit data. And so, you know, how do we handle that if, you know, if a mother birthing person wasn't screened at the prenatal, but was screened maybe at the hospital and, you know, screened at postpartum. So if we're missing data in some of these phases that we're supposed to be doing screening, how do we handle those missing data and assume that, you know, is it missing because, you know, for whatever, you know, missing at random or, you know, whatever, what do we do with that if we don't know conclusively whether they were at risk or not? And then finally, you know, should we add, you know, some of these curves to the R report as standard things that we report out? And, you know, what could we glean from this that, you know, we could publish and present elsewhere? So that's what I had. Happy to take some questions and or, you know, anything else that you want before I drop off.
Thanks, Mike. Does anyone have any questions? Then I come up here and ask. You come up here and ask your question. Sorry. I can repeat it if you'd rather.
I had a question about the ICC data. I was looking at the number of well-child visits, and I know across the different sites there's a wide variety. Are there any outliers with large numbers that could hit? Well, I'm thinking about my site because I think we had like 17,000 well-child checks or something crazy like that. But I also know that we haven't been implementing very well. So if you were to take out a large denominator like that, does it change that curve at all?
Yes, absolutely. And we've done some of that with some of the other, in previous iterations of analyses and so on, where we've looked at things by site or, whether it's an individual site or a subset of sites. Because your point is right on. You could have a brand new site that joins and their data collection methodology, or they're still learning, deploying ICC in terms of, screening templates and whatever, and training residents or training faculty or attending providers to do those screens. And that can have a profound impact on that. So I certainly think, we could do a control chart for every site. So I think, the challenge is, that would be a massive report. And so I think certainly we could include something like that as part of our standard reports, that a site report could include some of that for your site relative to the network. And obviously we could go down the route of statistical modeling in terms of looking for trends and so on, and controlling for all of the site differentials. So yes, long story short, yes, there's a lot of things we could do. And I think, the challenge is what would be most beneficial to help answer, some of these questions.
Any other questions? Do you mind coming up and asking?
So my question was, I know you looked at the race and ethnicity. Was there any data you collected for socioeconomic or educational level of these diets?
I only looked at race and ethnicity for today as more of a demonstration or just kind of a proof of concept, just to get people thinking. But we do collect insurance type, we collect education. And again, the caution there is we do have a number of missing data points on some of those demographics. But yes, long story short, we could certainly look at any of those, and I also mentioned like maternal age. Do we see any differences in that follow-up, that early postpartum visit timing across the age categories would be another demographic that we could use. But yes, absolutely, that could be something that, as a network, if the network says, yes, this is really important, let's go to the next step and analyze it across those demographics. Absolutely.
Any other questions?
You combine two variables like preeclampsia with ethnicity?
Mario's asking if we can combine two variables like preeclampsia with race and ethnicity.
Yes, we could do that. I think that the challenge starts to become does the now preeclampsia with severe features had a large enough N in terms of a denominator of individuals where that was flagged as a risk factor. But some of the risk factors had very small denominators. And so we could combine them. We could say, hey, all of these 4 risk factors are similar, so we're gonna combine them. That might help. So yeah, there's a lot of things we could do in terms of teasing out that interaction effect between your risk factor and race and ethnicity to see if there's an effect there. But it ultimately comes down to sample size, and so how you make sure that you have your data collection to optimize that sample size, and then also making sure when you create those categories, you have a large enough denominator to do that combination.
Any other questions?
And I just want to comment, Mike doesn't have to hear the question about it, but all of that data is just the data that we have, based on what's in the report, and Mike is sharing that, but none of that represents any actual like CQI efforts to improve those numbers. And so when you look at those and say, there's really not a difference in who we're, getting in early or who we're impacting, there's this is every one of those is like a new QI project to figure out how do we do this better for patients with, pre-gestation diabetes, gestation diabetes, preeclampsia, whatever the risk factors are, and see if we can get separation to get people who need to be seen earlier, engaging with care earlier, actually get care earlier. So, but this is. To me, those Kaplan-Meier curves seem like a good way to look at that. I don't know a better way, but first time I'm seeing that, it's we can continue to sort of discuss it. But I'm energized by that.
Just like wonders like vision level.
Is it Mid-Hudson? The Bronx one?
Is what Mid-Hudson?
No, Amy was asking, she was saying that the Bronx is missing. The IFH Bronx site.
Yeah, I'll have to look.
Well, he sent me a report earlier and I thought it was on there. Amy's concerned she broke something.
Okay, I'll look, Amy.
Right. Any other questions? Awesome. Thank you very much, Mike. Appreciate it.
Yeah, and
There may be some questions coming your way later while
Okay.
people absorb and look at the stuff, but thank you very much.
Yeah, and just like I said, in the presentation itself, I tried to just throw out some questions for both ICC and fourth trimester for discussion, thought. Again, I'm not necessarily looking for answers, but trying to just throw some of this stuff out there to stimulate thinking around things for publication. As Mario mentioned, CQI efforts. If there are things that would be helpful to include in the R report to help sites better understand this on a regular basis, any of that kind. I mean, these meetings are helpful for me because I get to do some proof of concept stuff and kind of bounce ideas off of the larger network. But yeah, as you discuss things the rest of the day, if other things come up, questions, or just, hey, this would be really helpful, just please let me know.
Thank you very much.
Hope you have a great rest of your meeting.
Thank you. As we transition to our next section, please, this is just kind of a continuation of the breakout session on the scholarly activity. So if you could please scan this QR code. This is really just getting an understanding from us, people who are interested in participating in some of the scholarly activity topics that we talked about, and also finding out if there were any topics that we didn't cover that you think are really important and that we should cover moving forward. So I'll give you a minute or two to fill it out. It's a very brief survey.
All right. So, yeah, and we'll also send this out to the network. So if there's people at your sites that you think will be interested, we'll also get the form out to them as well if they're not here today. All right. So I think kind of fittingly building off of talking about our data, we're going to talk a little bit about the PDSA cycle that we're more formally launching here today. If any of you attended our spring meeting, some of this might look a little bit familiar. We kind of, I would say, soft launched it a little bit back then, but really have taken a bit more time to really think about what we're going to be doing and building out like a timeline and things that we'll go over that here today. So the cycle itself is going to be focused on ICC. And I think based off of what Mike's data is and kind of what we've seen just internally looking at some of our data, we're really looking to improve our ICC screening and intervention rates at all of our sites. So overall, we've seen just about a 15% decline over the last 2 years. So we did run a data report from January 2022 to December 2024. If you're interested in looking at the R report, it is over on the table. You can kind of flip through it a little bit. So we've seen that decline. That would be that kind of lighter blue line on this graph here. The darker blue is the ICC screening rate when mom or birthing person is present. That has been stable, but often we assume that there are well-child visits where it's not documented. What we've seen oftentimes is if that first question is mom or birthing person present, if that's answered yes, then often the rest of the screen is completed, or at least part of it is completed. But often if that question is not answered at all, even if mom or birthing person is there, ICC is not being done. So we assume that there are some visits where mom or birthing person is present, but ICC screening is not being done. So that's why often we really look at that overall ICC screening rate, because that's a little bit more indicative of kind of where we're at for screening as a network. So we set an overall improvement goal as a network, but we also want to work with sites to set some site-specific goals. So working with you to figure out, what are your screening and intervention rates? What makes most sense for the improvement goals for you? What makes most sense to focus on? But that's in service of an overall network goal that we have to improve our ICC screening and intervention. Our cycle is going to last 2 years, so I'll go into a little bit more detail about what the timeline is going to look like. But your individual site projects that whatever you decide to focus on, that may be shorter than 2 years. Really, the timeline is up to you, however you decide to structure that, and we can work with you on that as well. But overall, for the network, we'll be looking at 2 years from now is when we'll kind of close this cycle and do a bit more analysis of the data and see if any of the interventions that we implemented have made a difference. The measures that we're looking at, so that overall ICC screening rate, that screening rate when mom or birthing person is present, the intervention rate for each risk factor, as well as the number of screens for each risk factor as well. So we have here kind of just listed out some intervention options. This is just kind of to give people a place to kind of get started brainstorming, but you don't have to necessarily choose an intervention that's listed here. But when we were kind of brainstorming a bit, we were thinking about what education interventions we could do. So that could be training or educating staff, educating your patients on ICC, like what to expect at your child's well-child visit, maybe making some patient-facing resources for things like that. Educating on the importance of ICC, kind of what is it? So that's a patient-facing, as well as the training and educating staff. Workflow changes. So this is changing that screening process. So some sites like to identify those risk positives before the visit starts. Improving data collection methods to ensure some accurate data reporting. I think, coming off of Mike's presentation as well, we know that there are certain sites that have missing data in certain areas. So that's also something that we can do within this cycle. If that's an issue at your site, we can work with you to figure that out. Incorporate some ICC workflow into existing clinical workflow, establish a kind of an ICC clinical champion. So our sites have, site champions, but maybe building out more of an ICC team. For example, at LGH, we've had a resident who has been helpful for doing some QI work with ICC as well, sending some reminders in the EMR, as well as some risk factor intervention improvements, providing multivitamins in clinic. We know that often giving patients that multivitamin multivitamin bottle right there in that visit is the most effective way to change their behavior and have them actually taking that multivitamin at the next visit. And then also creating resources and referral documents. So on the website, actually, we do have for ICC, depression, smoking, family planning, and multivitamin kind of patient-facing resources. Those are very general. So you can also tailor them specifically to your site and add some resources that are more local. But again, just before I move on, these are just a list of options. You don't have to be necessarily confined to what's on this list. It's just kind of a jumping off point. So this is our goal metric. So on the just January 22 to December 2024 column, that is the data that we're kind of basing all of this off of. So we see our well-child visit screen rate is about 67%. So our PDSA goal for the network is in 2 years to increase that well-child visit screening rate to 75%. Our well-child visit screen rate with mom birthing person is present, so when that question is answered, is 87%. So that's pretty good. We want to maintain that, continue that 87 or 85% or higher. And then for our intervention rates for smoking, we've been about 66.8 over the last 2 years, increasing that to 75%. Depression is very similar, also increasing that to 75%. Contraception intervention was a little bit lower, around 53.7, and increasing that to 65%. Multivitamin interventions are the lowest, so from 46.3 to about 60%. So we're looking really for about a 10 to 15% increase in the 2 years that we complete this cycle in. And this is the overall network goals. Again, we'll be working with sites to figure out what your site specific goals are based off of what your screening and intervention rates looks like. Obviously, that will be in service of this overall network goal. But, for example, if your smoking intervention rate is really good, we don't necessarily need to see a 10% increase there, but maybe your contraception increase is lower. So we want to focus on that a little bit more. So this is also registered with ABFM as an organizational PI project. So an organizational PI or performance improvement project is designed for organizations like us to support physicians in quality improvement efforts. And so that we had this project approved by ABFM for providing certification credit for any physician who is meaningfully participating through attestation. I'll go through what the meaningful participation is well. So you can scan that QR code, you can fill out that interest form. That also helps us kind of like kickstart with you. I know, we have certain site meetings and stuff that we already have scheduled, but if we haven't, we want to make sure that we're reaching out to everybody who's interested in participating and getting those initial meetings on the books so we can talk about what you're thinking about for your project. And you can also collaborate with other people on this project as well. If you want to work with another provider at your site, if you want to work, incorporate some residents, that also could work as well. Okay.
Try it from there first.
Is that working now? Okay. Great. And so, yeah, you can scan that QR code. We also have it listed under the ABFM catalog. So if you search us in the ABFM organizational PI catalog, if you search implicit ICC QI cycle, you should be able to find it there. I can zoom this in a little bit as well, too.
Team member, Scott.
Kudos to all of you for your name for all of this stuff, but especially this is a big good for us. This is a big tremendous opportunity, really boring burdensome requirement in a really fun, important way. So big love.
Yes, and we hope to do more of these projects in the future too, through the same pathway. So, yeah. Yep. Okay, so for meaningful participation, so these are the standards that we've set for us to kind of be able to attest to ABFM that you participated in the project and yeah, met their meaningful participation. So you'll create an implementation plan using 2 or more of the following. So that can be recent data that we can get for you from the R report. I'll also talk a little bit about a QI survey that we'll be sending out as well as part of this. You can do stakeholder engagement interviews, literature review. Again, if there's other things on this list that you think would be useful for your implementation plan, you're welcome to do those as well. You'll choose an intervention and implement that intervention at your site, and then review the data. So we'll run some more R reports throughout the duration of this cycle, as well as at the end. You can do chart reviews if that's relevant to your project, and then pre and post implementation surveys if that's relevant to your project as well. And then we'll just ask that we have quarterly at minimum check-ins with our staff, just to make sure that your project is kind of moving along at the timeline that it should, and also for us to be able to check in with you to see if there's anything that we can do to help support you for the project as well. So this is the timeline that we've drafted for the PDSA cycle. So that baseline data collection is already done for the most part. We are looking at the past 2 years of data that we had. So from that January 2022 to December 2024, we are using those as our baseline data metrics. Fall 2025, so this meeting here is where we are introducing the PDSA goals and the metrics. After this meeting, so likely in October, we'll be sending out a PDSA like QI survey that's based on the ICC screening and intervention. Our PA sites have already seen this. We did that earlier in the year, so won't have to likely do that again. But for our non-PA sites, for the most part, we'll be sending this out and you'll be able to complete that. We'll also be able to have the responses sent to you, so you can kind of use that as a way to potentially inform what you want to focus on just outside of the data as well. We'll ask things about like barriers and just other issues that you think might be contributing to lower screening and intervention rates. So all of that through this kind of October to December period will help you identify what the specific issue is at your site. So like I said, we're focusing on all the screening and intervention as a network, but maybe we only need to focus on one thing for your site. Can be more than one thing if there's more than one thing that needs some work, but we'll work with you to figure what that is. From January to June of next year, we'll have you implement whatever your intervention is and do some data collection in that first data collection period. That's inclusive of 2 quarters of data. That second data collection period will be from July to December. So at this point, we think that intervention will be implemented at your site. Things are kind of up and running. We're just kind of collecting data to see if there's any changes. That third data collection period will be January to June. Again, just assuming that these interventions are just up and running, still trying to see what the change is. And then fall at this meeting in 2 years, we will look at the data and see that we have improved our well-child visit screen rate to 75%. So in a perfect world, that's what we'll see. And I think that, hopefully we can get there through doing all of this. So this is our timeline. We'll send this out to the network as well. Again, this is the network timeline. Your project may have a different timeline depending on what you decide to do with it, but we'll be collecting data as part of this PDSA cycle throughout this time period. So I'll go into a little bit more detail of how this, might work in practice just in the beginning. If you come to our QI presentation tomorrow, these slides may look a little familiar. This is part of our methodology for how we do these PDSA cycles as a multi-site network. So, on the one side, we'll have our implicit provider champion, who is always kind of that person that has that communication link between our staff and your site. Residents and fellows are more than welcome to take part in these projects as well as any practice staff that may be relevant to whatever intervention you decide to do. That can be front desk staff, MAs, case managers, any APPs, whoever would be useful to have on this team. You'll have our staff, so myself, Anna, and Aisha, who can help out and meet with you and kind of move these projects along. Mike, who just presented, who will be helping with any data, as well as our committees. So often these cycles are kind of born out of our data review and our scholarly activity committee. So we have those resources as well. So kind of talked about this a little bit, but just the next steps are to kind of do that pre-intervention. So we have those baseline data reports already as a network, but we can run ones specifically for your sites over that baseline data period. If it's relevant and you want to do some qualitative interviews, often people find those helpful to get a little bit more insight into what some issues might be at your site, as well as those surveys that we'll send out. If you're kind of assembling a team to put these implementation plans together, work with them to figure out what the timeline for your project is going to be. And then once we get those data reports for your sites, what your kind of goals and metrics might be for your specific site. And we're always using SMART goals to do all of these things in our PDSA cycles. So identify that site-specific problem. So next steps after kind of this meeting and as we go into that timeline, identifying what your site-specific problem is, developing your intervention, so tailoring whatever intervention you choose to what fits your site's workflow, what your needs are, and then implementing that intervention and collecting the data over that period that we've identified. And I think that is it.
All right, thank you very much. So next we're going to move into some site-specific projects. So we're going to start with one from Maine, Dartmouth.
Yeah, it's just scroll. Okay. Hi, everyone. So I'm Caroline Lefebvre. I'm based in Waterville, Maine, Dartmouth, family medicine residency. As I said before, I've been coming to this meeting for lots of years, but just started really collecting data over the last year. Let's see, that work. So just to start with why I fell in love with this project. So those pictures, that's my oldest daughter, Nora. She's now 11. But I had her between my first and second year of med school. And when I wrote my personal statement for family medicine, I talked about how getting care from an OB, I felt like after I delivered, I was like, we'll see you for the next baby. And the pediatrician wasn't asking me any questions about me. And I thought there has to be some better way to connect these two things in this continuity of care. And that's one of the reasons I fell in love with family medicine. And this interconception care is exactly why that works or how we're collecting that data. So we're the blue dot all the way up in Maine. So why this is important for Maine, Maine's a big state, it's very rural, and we keep closing hospitals that deliver babies. So these are all the hospitals throughout Maine, and the ones in orange are all hospitals that within the last 6 months have closed their birthing units. We're down, can you guys see this is where we are here. We're actually like the southern half of the state, but there are not many people above us, but there's very limited care when you get up north. So we implemented this about a year ago. So our residency, we have 2 continuity sites for residents. One is based in Augusta, one's in Waterville. I'm based at our more rural site in Waterville, and that's where we started. So we started doing screening forms, did an education session for our staff and faculty and residents. Then started looking through chart data in January, and then we had a couple residents who presented it at their scholarly symposium in May. This is what our screening form looks like. We don't have Epic. We have a rather antiquated medical record system that doesn't interact very well with other things. So we're collecting all of this on paper. So the parent gets the this sheet here, the questionnaire, and then after the visit, we collect these sheets in a box in our preceptor room, and then we transcribe everything from the chart onto our data collection form, and then that goes into an Access database. So it's a lot of work for us to get to that point, but I think it's really important. We do have Epic coming, hopefully, if we have enough money for it, in the next couple of years. So I'm hoping it'll be much easier to do it. They told us Epic will replace over 100 different systems that we use within our hospital. Like we have different billing, scheduling, outpatient, inpatient, infusion clinic, all use a different system. So this is just looking at our screening numbers so far. So we identified about 357 visits from when we started collecting data about November of 2024 till August of 2025. It was just pulled from that billing data of kids under the age of 2 that were presenting for something that looked like a well child visit on the indication. When we went through the charts, about 59 of those were acute visits that didn't actually count as well child visits, and then the birth parents were only not at 13 visits. So that was about 300 eligible visits that we screened from. 88 of those visits, we didn't have any forms and nothing was documented in the EMR. So that was about 67% we had completed. So this very much goes right along with the QI project we're talking about. The part I thought was most interesting was, does this differ based on if the child is seeing their PCP? And then does it differ if the PCP of the birth parent and the child are the same? So here's all our visits over here, and somehow we had more encounters than we actually pulled from the visits. I don't know. That's what we have. So 37% of those, they weren't seen by the PCP, and only 36% of those forms were completed. So if they were seen by their PCP, 52% of the forms were completed. So more likely to fill out the form, have it end up in the box, and have something documented in the chart if they were seen by their PCP. And then I didn't break it down if they were the same, but just looking at, are the birth parent and child PCP the same? 25% of the kids in our study, they were, which is great. 29%, the birth parent was at a different practice. And then 46%, they were both Maine Dartmouth patients that had different PCPs. And we do have our site at Maine Dartmouth, we have 6 attendings, 4 NP and PAs, 12 residents across the 3 class years that we have. And then we have a pediatrician who's there 2 full days a week, and has a decently large pediatric panel. So she sees about 20% of the kids that were included here. So she's a big chunk of that. Questions about this? No. Okay, there are a lot of graphs. So then I looked at the completion rates by the type of clinician they were seeing. So attendings, we really didn't do a great job. I think part of that, my rate was about 52%, which I was a little embarrassed to report, but I know I looked at the forms for all of the ones that appeared in front of me, but I was not always the best about documenting it in the chart. Our interns, if they were seeing their own patients, they never completed it, but there were only about 2 or 3 visits that our interns had seen. Our pediatrician, Dr. Lewis, she's amazing. She was the best at filling them out, mostly because she's a good friend of mine, and I encouraged her to keep doing this, and she likes to follow rules. So, and I think it's also just a habit. She does so many well child visits throughout the day. It's part of her process. It's in her macro. She uses the same one all the time. And so if she was seeing her own patients, that completion rate was really high. And then our residence was hit or miss, better than our attendings. I think Hope Huntley, one of our residents who's here with me, is working on this project, had the best numbers, partially because she's involved in the project. And then I definitely identified some residents who I'll have a good discussion about how we how we do things, so, or what I would like them to do. So before we did the training, we did a pre-survey about what everyone thought would be easiest to implement from an intervention standpoint. So this is 35%, and there are about 20 clinicians that responded between residents, attendings, and NPs, PAs, said that depression screening or depression intervention would be the easiest. And then contraception intervention would be the hardest. And then after 6 months, we did it again. There were fewer people that responded to that, but it pretty much stayed the same as in terms of what people thought would be the easiest and hardest. And I'm going to go through the data. It actually didn't fit this in terms of what we actually did. So this is our results about contraception use, and then how we recorded in terms of an intervention. And so yellow is no intervention was done, red is someone picked NA, and then blue is an intervention of some kind was done. So we had about 30% of our patients had a tier 1 or an IUD, Nexplanon, or tubal ligation, or a vasectomy. That was another popular one listed. And then 30% were in this less effective form of contraception or not using any method at all. And I highlighted this as the kind of highest risk use that we could have intervened more on that group. In terms of smoking, only 10% of the patients were current smokers. 24% of them were former smokers, but we didn't do a great job about intervening there if you look at the size of the bars. For depression screening, 38% of patients, the maternal birth parent had a history of depression. And so how these graphs are broken down here, this one is they have a history of depression, but their screening was negative, like their PHQ-2 was 0 or the EPDS was low enough they didn't consider positive. This was they had a history of depression and screened positive. And this is they had a history of depression, but no screening was done. And then this section is they don't have a history of depression, and this is we don't know because it was hard to find on the chart. Their PCP was not within our EHR, so we couldn't tell. So the two I put the black bars were what I considered the highest risk categories where they had a positive screen for depression. Here's oh, that shouldn't say smoking status. It should say multivitamin use. I'm sorry about that. So about 44% of patients were not taking a multivitamin. But of that 44%, I think it was 40 out of 74 of them were on either an IUD, Nexplanon, or had a tubal ligation. So pretty good birth control. So just a reminder of what we thought was the easiest and hardest to implement. So depression being easiest, contraception being hardest. This is how well did we do at intervening. So for contraception for the at-risk category, we only intervened about 24% of the time. Smoking was about 24%. Depression was 50%. But we didn't do any depression screening for 36% of patients. And then for multivitamin use, we only intervened 23% of the time. So lots of work to be done, but here's our starting data for our QI project when we go back and do this. But our impressions aren't exactly what is being done in practice. So that's what I've got. Questions? Yeah. There's a macro in the EHR that says this parent is a current smoker, recommended cessation or something. And sometimes it just said this patient is a current smoker, nothing. So I counted that as no intervention was done. Or I only had the screening piece of paper and nothing was recorded in the chart. So yeah. Yeah, yep, I grouped them all together just because there were so few numbers. For the depression screen, the one that was interesting, almost all of them were already in treatment. So it's kind of the low hanging fruit of like, they're good, they're being treated, as opposed to referring for counseling or starting medication. I would love at some point to break it down by how well do we do at intervention based on are you the PCP or not, right? Because you already have a relationship with the patient, hopefully be more likely to intervene in those cases, but to see if that actually pans out. So, yeah.
Thank you for presenting. You're so close to this data, like some of us, once you get into the EHR and it's sort of like, you're not watching the visits, and you're not looking at the data, and it's being extracted, automatic way. So you're in it.
Yeah.
Which is space to be, but also great safety. So what has been the reaction for your program and sort of taking something that wasn't previously been done, for really collecting and seeing this data?
Yeah, so I haven't presented this yet at our site. I'm going to the next time we have a team meeting, hopefully. It was presented similar data, only up to about March of this year. I went all the way through to August for today. But it was only done in our scholarly symposium setting, which is just attendings and residents, not necessarily our program staff that are doing a lot of the groundwork. I will say when I said, I want to hand patients another piece of paper to fill out, I got a lot of pushback of they get so many pieces of paper, how are we going to give them one more? And our pediatrician in our office and I actually spent a lot of time going through all the pieces of paper and deciding what's going to be handed out at the front desk. What is our MA going to give them? And also, can we not just keep copying the same form? Like, let's put it on nice paper instead of when you can't read. So that in and of itself was a good work that we had done to kind of simplify what we were doing in the office. So, I don't know if some of the missing forms are people just didn't fill it out. As I was looking through the data, there were a couple of forms that got sent to scanning instead of into the box that I was like, oh my gosh, do I have to look through all 100 visits that we didn't, or 88 visits, but not all of them have it. So I think more education about how we're collecting the data, where to leave stuff, but it is another step that everyone has to do for these visits when we're already swamped. People aren't finishing notes, for a while. And I think it has felt like one more thing, but it is such an important piece of work that we do when you think about it in the grand scale of the patients we're taking care of. Yeah, and actually I talked to one of my colleagues yesterday who's involved with our Maine Medical Association, that they're looking for an intern to create resources to talk about depression groups throughout the state. And so I think this is a great way to involve this. And I've had some local college students be involved in collecting data. I had one over the summer and one in January. And so they did a lot of the chart review and data entering. I had one who was a joint biology and computer science major, so he made the Access database for me, which was very helpful. Yeah.
Time how we handle interventions if it's going to take time. It sounds like we resolved screening time by actually in regards to any thoughts on how we would do interventions in a timely manner for.
I think that's a great question. I think involving more of our MA staff, if they're screening positive, to hand them something to start reading or notifying us that happens. We at Maine General, there have been lots of budget cuts due to cuts to Maine Care, which is our Medicaid funding, and we're losing staff. So all of our staff have more that they're responsible for. We have people leaving. It's turnover every time. So whenever we have someone new or a per diem person, it's like, I don't know what this piece of paper is, right? So it's keeping everyone on up to date as to what we're doing. And keeping residents up to date, right? We get a new crop every year. And so every 3 years, people have forgotten what we talked about. So I think having more things posted on the wall in the rooms that someone could look at, like some of the handouts that I've seen and that people have come up with, I think would be great to have in our exam rooms of resources. Yeah.
Easier way back to but a couple things we need to get resident and faculty buy-in. The length of the time for well visits from 20 minutes. Well, that
I know.
Say take care of you the way you're being visited.
Mhm. Yeah, I will say Stephanie Lewis has 40 minutes for all of her well child visits, for all of her visits, because she has a resident with her. We do not. We have 20 minutes. And so, yeah, oh, okay, to get people, yeah. Yes, so timeliness, I will say we just recently got an AI scribe that we can use, which has been a game changer for me to finish my notes. I was notoriously behind in finishing them, but we're deciding when we let residents start to use that. So. We're the only site in Maine, and I would love to, thinking about from a rural maternity care crisis that we're seeing, with all these hospitals closing, people are having to travel so much farther to get prenatal care, just even getting follow-up afterwards. If you have to drive an hour and a half with a newborn, that's terrible. And we've seen it. And even the site that is north of us, Eastern Maine, is about an hour north of us. There's an insurance standoff with one of the major insurance companies in the state of Maine. They're not taking anymore. So we've had patients come to us because they're like, they won't take it. And they live in an hour and a half away from us, and our hospital is 20 minutes south of our clinic. So it's just crazy what people are going through. And we think like, oh, they're lost to care, they're not following up. There have to be better ways that we can do it with local resources that we have. So I think there are options for that. There is another thing I just heard about today where Maine Care has gotten a large amount of money for transforming rural health, but they have to submit the application within 6 weeks of what the ideas are for doing that. So it's very short timelines. So I was wondering if we could get other sites within Maine involved, would that be something that we could do with that funding? So yeah, yeah. It's
and we feel that you could be sharing data with them. But for Maine, you are running this is the entire interconception care demonstration project for the entire state at your site. So they don't have to know about everything else that happens anyplace else. Just claim it as the thing that's going on, and that this is the idea. If we need more states and larger systems to sort of just pick up on this and say, yes, we're gonna that is an idea, and this funding we're looking for ideas and just help them catch on. Because as far as they know, this is sort of like the first time they're hearing about it.
Yeah. No, I'm hoping to do that right. And it's also finding the time within our teaching load and other little, so I do have pictures. These are lovely residents that I'm acknowledging, but also these are my people. So my med school baby is 11 now, and our life is chaos because we have just keep adding dependents that my wonderful husband's taking care of today. But it's finding the time and passion to do those things, like applying for grants. I will say coming to this meeting every year is always such a inspiration and boost to find the time and energy to do it. And I've always felt that way since I started coming as a resident. So yeah.
Are, well, depending on
Hmm.
want to prescribe NRT, can't do it in baby start with can, but also a lot where to do that. Yeah, kids do. Then we got a more complicated question of, can you then create a chart for mom and mom's not part of the clinic? Do they need a consent to treat in order to then have prescriptions and all the rest of stuff? I wonder how you guys have done that.
I think in the places where we prescribe something from the visit, I don't think any of the ones we've done from smoking cessation, it might have been just encouraged to quit. But I know I've prescribed birth control pills from the baby visit, but then making a mom visit to even just record, we talked about this today, takes going to our checkout person, making a new appointment. It's like 100 clicks to actually add them as an appointment time and check them in and get vitals and stuff. So often I'm just like, you're my patient and I'm just going to say we're doing this and hit send. And so it's not captured anywhere. So there's definitely, it's work we're doing that we're not necessarily billing for or capturing very well within the chart. And right, we all know there's plenty of that stuff we do all the time, right? You get a portal message and you end up changing something or modifying something based on that when they're not actually in the clinic to see you. So. It is not, but I haven't asked. So, and most of them are like, they're my patient, right? I take care of both of them. So it's the same as if, they sent me a message that said, I want to switch to this, or I want to do, this isn't working or something, or we've captured it there. Great. Well, thank you.
Thank you.
All right. Next, we are going to look at some different multivitamin projects happening in the network. So the first one we're going to do is at LGH.
Hi, everyone. My name is Kanza Bajwa. I am a third-year resident at Lancaster General Hospital, and I have this project that I'm working on using ICC data about prenatal multivitamins and trying to increase the intervention rate. So kind of talking about the problem that I'm addressing, we know that ICC provides a great opportunity for us to screen for multivitamin non-use and to intervene if needed. I am specifically looking at one of our clinics as part of LGH. It's the Downtown Family Medicine Clinic, so DFM. This is the data is consistent with what we've seen, is consistent with what Mike has just kind of reviewed with us. There has been a prenatal multivitamins risk for non-use is one of the highest, but the intervention rates has remained one of the lowest. I chose about a 6-month period to kind of focus as part of my project and as part of this, like the poster that I'm doing. But I think if we were to extend this for like over the last few years, it would be consistent. And it's consistent with our other like clinics as well. But I am focusing on DFM just for the sake of doing the interventions in one clinic. So my objective was to first determine the barriers for ICC screening and also for like providing intervention. And then after we determine the barriers, to design interventions tailored to these specific barriers, and then to eventually target and to increase the overall intervention rates for multivitamin non-use, and measure that by ICC forms. So continuing kind of the data collection as part of, our well-child visits. So this is the ICC workflow that I kind of laid out, and I'm going to get right back to this, but just talking about my methods. So I specifically chose not to do like survey-based collection just because I think we get a lot of surveys, and I wanted to do something a little bit different to see if I would get data that's a little bit more objective. And I chose observational data, and I did that by going to the preceptor rooms where we precept, all the residents precept, and then just going through like all the well-child visits that were seen that day and waiting for the residents to come in and precept, and then going through like this workflow, with them, or like, charting along with them to see if like this happened, like this workflow happened and where the barriers were. So going through kind of how the workflow is, we have well-child visits when birthing person is present. So either the ICC is not mentioned during the huddle, which is a missed opportunity, or it is mentioned, but the ICC is not given to the birthing person, which is another missed opportunity. If it is given, the birthing person may not complete it. The birthing person or the ICC could not be reviewed. So there was multiple like missed opportunities or barriers that were identified through this workflow pathway. The end is kind of these like 4 kind of outcomes, and essentially making sure that either the birthing person already has a multivitamin, or it's recommended and recorded somewhere and discussed, or you give them prescription, or you supply them with a sample of multivitamins, which we actually have in all of our clinics. But what I found during my barriers that were identified were not everybody knew that we had multivitamins to give out for free. So that was a huge, room for improvement there. So to discuss some of the other barriers, these are like the most common ones that I had identified. There was some lack of understanding regarding which well-child visits require ICC completion. So they're for two years for 24 months, and there was a little bit of some of the residents or some of the newer residents, they thought it was for a year or for a few months right after postpartum. The postpartum period, 6 months, there was a little bit of confusion there. There was unawareness that free multivitamin samples were available, like I talked about. There was uncertainty about where the samples were stored. So we have this this flow chart that is actually pasted around, but I think sometimes we don't, or the residents didn't know that there is a flow chart that says where the samples are stored and how you can go and get them, and then document in mom's chart that you gave her the multivitamins. So kind of educating about that. And then the last thing, which is interesting, because I didn't actually this is something I didn't really recognize before, but a lot of the residents said that the samples were stored in the inconvenient location, which they have to be stored in the medicine room, and it is locked. So it is another barrier. And we have 3 pods, and the medicine room is closer to maybe some of the pods and a little bit further away from some of the pods. So it was how can we move this? Can we make this a little bit more in a centralized location, or can we change how they're stored? So interventions that were tailored. One thing I didn't mention here, but one thing, we actually can't really change how they're stored, because I actually spoke with the the clinical, the nursing supervising staff, they said that because they are like medicines, or they have to be stored in that room, and there wasn't really a better way to fix that. But things that were identified that could be addressed and could be changed, and I designed like specific tailored, interventions. So one thing was just to review the ICC workflow with new staff members done at our pod meetings, especially for the staff members who have had high turnover. This could be really important. The second thing was to review the ICC workflow at block conferences for residents, and for the interns, but as also for the second and third year residents who might just need a refresher and just a good reminder. We have 13 residents per class, so it's 39 residents, and sometimes maybe they missed one of the block conferences, they weren't there. A good refresher more times than once a year might be helpful. And then to send monthly email reminders to residents and clinical staff and faculty, just to reminder to complete ICC screening. And that has been kind of my role, to send out like monthly emails as a reminder, but also as a way to share some of the data to keep things like interesting and to keep everybody involved. If there is like a specific trend that's seen that month, we'll highlight that, but also just serves as a good reminder every month that we are, still doing ICC, and just to do for everybody to like be on the same page that we are supposed to be doing these at all the well child visits. So the results here, they are preliminary. I am still collecting data. So since the initial like 6-month period was from June to November, I want to continue that to kind of compare June to November for this year. But this just kind of is only June and July, and because I submitted my poster in August, so it doesn't have all the August data in it. But just to kind of go through what the data show, the trends that are seen. Our overall ICC screening rate is now 68%. So it was 70% before the interventions. And I'm attributing this to like the July being half of the data here. And as like new interns, and we did see a dip. I compared it, there was a dip last year too. There always is kind of a dip, but I am thinking that probably when we have the 6-month period, that will be a little bit more of an average, and might not show as a dip anymore. Multivitamin risk is actually a little increased, 32% before the interventions, which is the June to November last year. And then this is now 45% in these 2 months. And then multivitamin intervention has increased a little, like slightly. So I kind of have the same data in a chart view, so make it a little bit maybe easier to like compare, but there has been a little bit of an increase in the multivitamin intervention. And again, just so we reiterate, this is only 2 months, so I expect the trends to hopefully stay that way and maybe have a little bit of a higher difference in the intervention rates there. So some limitations. I only selected a 6-month period for comparison, but I think if we were to extend this, the trends would be the same, but I think it probably you would have more, higher sample number. And then some identified barriers, like we discussed, could not be addressed, specifically where the multivitamins are stored. That is like a barrier that we couldn't really address or rectify. And then there are some limitations in the amount of data that could be collected because it was observational and it was time consuming. So maybe there were some barriers that were missed because of that. So next steps, like I said, I'm going to complete that 6-month of data collection and analysis for comparison with the 6-month period before and after the interventions. And then there is, I think, a good idea that we have kind of discussed is to develop a standardized training for clinical staff and residents. So this is something that maybe could be done like every year or every so often. And this could be in the form of like a script that we know like what we're kind of like what we're going to say, or like a recorded video or something that's a little bit more standardized and doesn't take a lot of effort to like repeat every year. And then continue sending monthly like update emails. It doesn't have to be monthly for some of the sites, but it could be like quarterly or some type of email reminder that shares data, but also like reminds people that, you know, about ICC. I want to thank you, Dr. Moyer, who is our implicit champion at LGH, and Anna and Emily for all their help with this project. Any thoughts, any questions or comments? Mhm.
So there's
Yeah. Mhm.
you create that, please share.
And if you want to see the full poster, it is marked on the yellow page. So before we switch to our next section, I just wanted to highlight another project that is focused on multivitamin use. We kind of have 3 happening simultaneously while also collaborating together. So we have one at LGH, one at Rochester, and then one at Mississippi. Unfortunately, our provider champion from Mississippi couldn't be here today. So I just wanted to highlight because they took a different approach and looked at it. These slides will be shared. I'm not going to make you read this whole thing, but I wanted to pull out a couple things. So really what they were doing was surveying the patient on what the barrier was to taking multivitamins. So why were they not taking the multivitamins? So overall, they had 231 as their N, and they only had 151 that answered the reported barriers for the multivitamin question. Some of the reasons were lack of understanding of importance, decline to answer, which was a large one, which I think, you know, doesn't really help us, doesn't give us a lot of information. So it's definitely one area that would be really important to try to drill down and look more into it. Belief that it's unnecessary, they forgot to take it, cost, and then there was another reason. So again, some things that they highlighted was that with that other reasoning, it would be beneficial to be able to gather some of that information of what those others were. So needing to have some follow-up dialogue to better understand the individual barriers with that. But also, I think, just to preface this too, if for those who do not know, University of Mississippi is a very large pediatric site too. So this is not, they're not able to obviously hand out the vitamins in office. So a lot of what they're doing is more of just the recommendation, and they're not able to write a prescription either. So I just thought, you know, highlighting after Kanza's what she was looking at and doing, and then what Mississippi was doing, how these are good examples of how we can take one risk factor and really look at it in multiple different ways and very much site dependent, and then bring these similar things together, because both or all 3 of them, Mississippi, Rochester, and LGH, had a goal of, you know, wanting to look at specific things at their sites to improve multivitamin intervention. So how they approached it though was different, and being able to look at those different ways. So I just wanted to highlight that for Mississippi. Any questions with that? Again, you'll be able to see the poster. This was a collaboration between the provider champion and a medical student that presented this. All right, so next we'll have Mario.
Okay, back again. Earlier today, we talked about some of the grant funding for the network, and what's been important and critical for our growth is that funding from the Pennsylvania Department of Health, which actually started before the time that I was really actively involved in the network, and has really continued until June of 2025. And the Pennsylvania Department of Health is still a critical supporter of the work that we're doing as a network, but I think it's really a time to sort of pause and think about what happened as a result of that funding and what we're able to do. Of course, that funding is directed at Pennsylvania, but the funding, as we'll talk about, is really about the infrastructure that helps support our entire network, right? So IMPLICIT in all of its 12 states and 51 sites has benefited from some of the investment from the Pennsylvania Department of Health. So we'll get a chance to sort of look at that and then think about it, how you may represent and interpret some of that information to think about how we can leverage other state departments of health or other health systems to think about support for the network as opposed to the work in individual sites. So our most recent grant started in 2020, but there was a precursor to that, which started in 2016. And that relationship actually started when the March of Dimes in Pennsylvania had funded a couple cycles of small funds for our network to meet and to gather and to have some seed money. And after doing that a couple times, the March of Dimes has to move on to some other, grantees and different awards. And a personal connection was made, between Dolores Smith at the March of Dimes and somebody in the State Department of Health. At that point, there was a COIN program, and they were looking to do interconception care, which was, had been just one piece of clinical care that there was dedicated funding to. And so they said, well, who do we know that's doing interconception care? And of course, the IMPLICIT network was sort of hanging alone in that space. And so for actually it turned out to be 3.5 years. It was a 3-year grant, but the way that it started, it ended up being 3.5 years. $190,000 a year went from the Pennsylvania Department of Health directly to the Shadyside Foundation and the Shadyside residency program, part of UPMC, and was led by Lisa Schlar. But that money was enough to get IMPLICIT's first network manager, somebody named Jess Brubach, who helped get academic publications and sort of bring the network together, and was, a dynamite in getting people sort of interested in sort of the work that we're doing, and just can connect at conferences like FMEC, and just really starting to move from a faculty project to a real network. We had the chance to extend that funding in 2019 and sort of apply again. And so we said, well, let's what can we do differently and be competitive that the state would allow us to get that funding. And so we were successful in having an extension of that funding for a second round, which was different from June or July of 2020 until June of 2025 that just ended. And in that work, we expanded our budget to $290,000 a year. And what we had proposed was to not only extend the work that we were doing with IMPLICIT interconception care, but also to start and evaluate our 4th trimester project in Pennsylvania. And so there were some transitions that were happening around this time, moving the network from its residency location at UPMC Shadyside and to the University of Pennsylvania's Academic Department of Family Medicine. I continue to support that grant as a co-PI with Lisa Schlar, who then was able to transition her role and leadership in that grant to Stacy Bartlett. And so, just having the infrastructure of multiple faculty, different parts of the state, and the ability to extend and expand the size of our team from one network manager to, more than one coordinators, one in the East and one in the West, has really been transformative in having all of the infrastructure that we needed to build out this network. So I just sort of wanted to mention that, and we'll talk a little bit more about what those actually did. So what did 5 years of funding, the last 5 years support, and what should you think about adding into a grant or advocating for when you get the chance to say, what do you need to do the work that you're doing around maternity care and primary care, around postpartum care, interconception care, to do your implicit work? Well, we needed a network manager and a leader, somebody who's not a busy faculty physician that has other sort of clinical responsibilities and can be pulled to patient care, somebody whose job it is to sort of support the work and all of the sites as part of the network. So the grant helped supported that, not fully, because there's lots of sites outside of Pennsylvania, and so the dues that everybody pays into implicit, this is what we're getting is sort of some of that staff time. We had some staffing support to have the coordinators and their salaries in Western PA, Eastern PA, and even partially, part-time coordinator in Philadelphia for a little while. It allows, our staff to sort of get to conferences like this and to get to meetings where we can do consultative services and things like that for other states and to expand the network. It funded some of the network projects that we did. We did some work, 2 or 3 years ago around implicit bias training and sort of the move to make our network focus on health equity. We used some of that funds to complete the ICC toolkit. The update, the original one was, I think, published in 2015 or something like that. We redid it with all of the sort of new information that we've learned from doing ICC and multi-sites for the amount of time that we've been doing that. We use it to start our funding and the work on the 4th trimester toolkit. We use it to build that new website, www.implicitnetwork.org. It is a fantastic website. You should be proud to share it with colleagues, friends, and leaders in your community. We did a Pennsylvania site meeting just for Pennsylvania sites in June, I think, of 2023. It helps fund and bring speakers and honorarium for our webinars and our health equity work. That's part of what we do. And we use it to buy supplies. It funds a lot of prenatal vitamins that are distributed at UPMC sites and other sites in Pennsylvania. Some of the network materials, including sort of the resources that sites use, and blood pressure cuffs that have been used to give to patients to screen for elevated blood pressure in pregnancy and postpartum care that otherwise, now sometimes the hospitals or health insurance pays for that, but they weren't previously, and some people don't have access to those resources. So all of these things are sort of things that are sort of worked into that grant work that we're doing, besides just the data collection that we hear and see all the time. So in July of 2016, when that funding started, there were 5 sites in Pennsylvania who were doing part of the implicit network, and they were doing interconception care only. There was no 4TM back then. And part of that first round of funding was to not only do ICC and to do better screening and improve our intervention metrics, but also to expand the number of sites in the state. And the goal was to have 2 per year for 3 years, or to add 6 more sites. And during that period of time, the network grew from 5 sites to 12 sites. In 2020, we started again, and we said to the state, we already have a network. There's already 12 sites where, we're going to continue to try to grow, but it takes a lot of effort. Like, the more that you have, the more that you have to maintain. Like, let's not grow too much more. Maybe we'll add 1 a year as sort of a goal, but also try to bring in that 4th trimester work. And so that's what we agreed to do, and that's what that grant was about. And so we grew basically about 1 site a year every year of that grant work until 17 sites that are part of the implicit network in Pennsylvania today. And I will say this about what that network means, and having a coordinator in Western PA, a coordinator in Eastern PA, 17 sites in Pennsylvania that are part of the implicit network, and 17 sites that share data in the implicit network. So 100% of sites share data, which is not true for the entire network, but that's what infrastructure means. So now, currently in Pennsylvania, you can see, there's Allegheny County is where Pittsburgh is, and most of those are UPMC sites, but really sort of the highest sort of concentration of implicit sites. You see a lot in Lancaster County as well that are sort of derivatives of the Lancaster Family Medicine Residency, but we see implicit sites in 8 different counties of the 67 counties in Pennsylvania. And so we actually use this information. Recently, there was a grant that
in Pennsylvania that basically excluded Philadelphia and Allegheny counties. It was like everybody else is eligible except for Philadelphia and Allegheny counties, which is where, UPMC is based and also where Penn is based. And so, but, our argument is that implicit is really touching lots of different counties, even if some of the staff and the resources and the organization are based in Philadelphia or Allegheny County. So, and we were, totally, we didn't get the grant, but we were qualified and not ineligible to do that grant. So I think having representation in multiple counties says a lot. And we'd like to see that type of work also in other states, including right here where we are in Ohio. So what kind of impact does it have? Well, looking back at that data, if you were to run that report like today or maybe yesterday when this report actually was run, over that period of time, over 11,000 dyads were impacted, at implicit sites in Pennsylvania. Okay. You want to add that to the 9,000 in that first round of funding from 2016 to 2020. So just pause for a second to think of what 21,000 families look like. It's like, think of about 100 families, like that would take up like this room, like 1,000 families. But 20,000 families would be this entire convention center of work, of families that had opportunity to talk with dedicated healthcare providers about their, preconception, postpartum care, and their maternal health, most of which were occurring outside of visits for themselves. So just, this is not a lot of funding, but, when you think about what we do, we counted in like the number of like well-child visits that you've seen in like the last quarter. We look at the monthly data, we track it over time. We look at these small numbers, but the cumulative impact of what we're doing is really phenomenal. But, that's in this 5-year period, 11,000 dyads and almost 50,000 well-child visits. And so you can see the absolute number of interventions that are sort of being done. And I think it's really impressive when you think about what happened as a network. I'm not going to spend a lot of time on these sort of slides, but these are similar to what Mike has previously presented today, except specific to Pennsylvania. And what I think is impressive is like the unbelievable robustness of this data. Like, I can say this number in my sleep, but, maternal, like a birth parent is present at 94, 95% of well-child visits. Like there's no doubt about that in my mind. Like this, like look at this data, like it's always there. It's always consistent. It's been that way for a long time. We established that is the case. And so there is a feasibility of doing what we're doing. And we can see that the screening rates ebb and flow over time, and they've been pretty good in Pennsylvania, and we sort of, have maintained that despite some of those sort of challenges with the pandemic that Mike mentioned earlier. We see smoking risk and intervention rates, and when you sort of look at this at a macro level, you do see that the smoking risk positive has declined a little bit from about 17 or 18% to more like 10 or 11% as it is today. Unfortunately, our interventions have declined a little bit too for the risk positives, and so there's something to work on as well. We're also a happier state as a result of implicit. I'm just kidding. That's not true. You can't determine that from this data, but maternal depression, screens have sort of declined a little bit from where they were, sort of in that COVID period until, where they are today. But again, robust data that, should be very predictable about what is the likelihood of somebody to screen positive for depression in this sort of 2-year period, postpartum. We have that information here, and I'm very impressed with the intervention rates for screen positive. And, like this probably we probably started at those 50% rates like Maine was just sort of presenting, but it really, if you can say, when I do identify that the birth parent is present and has evidence of depression, that we actually do something about that more than 80% of the time, like that is what this is about. It's not about getting multivitamins for somebody who has an IUD that has, whatever, like that is an intervention, but it's not that likely to, create a difference. But when you can identify people who are at risk for a mental health disorder or substance use, and are sort of, getting care at the pediatric office during that interconception period time, and do something about it, that's what we're there for. And that's where we can make a difference. See, family planning, I think we've changed the definition of sort of what risk positivity is over time. I don't know if that's captured in this data or not, but that risk positive has had a steady increase over the last 5 years. But our interventions have sort of hung steady around that too, and there's room for improvement as well. And the same for multivitamins. We see the same story. So we have some, robust data, not too dissimilar from the network as a whole, but this is information that has been tracked for key parameters in Pennsylvania over the last 5 years. As one of the sort of stipulations of the grant, and any grant that you get from the Pennsylvania Department of Health, or probably anything from the Pennsylvania government, is that you have to do client satisfaction surveys. And so we said, well, what do you want and how many? And they said, design your own survey. We don't care. It doesn't matter. It can be a convenience sample. Like it's just something that we had to do. So we did do surveys of parents who have been exposed to interconception care models at a couple of sites, and UPMC sites in Lancaster and at Penn and Philadelphia, and asked these questions, which we developed a long time ago and we hardly ever used. But, I think I would go to the last, couple of questions. I'm happy with my overall experience during my child's appointment, and we're seeing 100% agree or strongly agree. And that last question, which is, I think that all doctors, healthcare providers should ask mothers, birthing parents about their own health concerns during their child's appointment. 97% sort of agreed or strongly agreed with this statement. So we think, is there a sort of, what is the patient perspective of this? And of course, this is just a random convenience sample, probably a little bit biased because somebody's going in right after the visit, but we see strong favorability for the work that we're doing. That where dyadic care, where maternal health care at pediatric visits is not only acceptable but appreciated and and sought out by parents who are in that space. So I want to focus on sort of like what are the takeaways of having a funding mechanism like this, and where do we go from here? So what did we learn? Our work in maternal health innovation totally aligns with state health goals and planning, right? So currently we have a Pennsylvania Maternal Health Task Force. We're asking these same things. How do we find new opportunities to get people to do screenings and get connected to care, and avoid pregnancy if they're not looking to get pregnant, and to have healthier pregnancies? Like these things have not changed. These are healthy people goals. They're state goals. Like everybody's looking at these same things. We know, as I mentioned, what the staff does. I mean, they're doing quarterly calls and check-ins with sites. They're helping you to fix the data. When you're having a hard time figuring it out, we're sort of working through problems. We're sharing QI opportunities. We are sort of tapping on each other's shoulders for grant opportunities and say, can we collaborate on these things? But it really depends on staff and that infrastructure. So it's hard to just have a QI network where you just get a bunch of providers together and think that you're just going to improve care by everybody sort of doing the same thing. It really requires this table right here and the organization of having a spring meeting, a fall meeting, these weekly, the follow through that happens in between those meetings to really make a difference. $290,000 a year is not very much at all. The NIH gives, $500,000 a year for 5 years to answer one clinical question about which is better, A or B, in some subsample of a chronic disease or something like that, using a database that probably already exists. $290,000 to pay for the staff to do the programmatic development, to do these meetings and collect all this data and answer these questions is nothing. And yet we're able to do all of this and to run this network on relatively sort of shoestring budget, I think. I think it says a lot about the work that each of you contribute individually, which is uncompensated, all of the value add from the team that we put together, which is really adaptable and effective. And really the resources of Mike Horst, who doesn't get enough credit for being involved with the Implicit Network for over 20 years, sort of collecting and being able to analyze all of that data, and did that for a long time with almost no compensation. So, just thinking about, we could actually do a lot if Melinda Gates comes through and we get $1 million. Like if we can do this with $290,000 a year, like, woo! This is, we're going to have more than those little spinach pastries for breakfast in the future, okay? And I really want to think that, while each site in the network is important and we count our sites, you know, like I think that it's important that we've grown. Like it isn't that, I mean, where will we stop? Like we should stop counting sites. You know, when we do like pediatric care, you're like, how many words do they say now? 1 word, 3 words. It gets to be 6 or 10, and then we're like, we stop counting, right? Like at that point, it's not about how many words you can say, it's what you can do with it. You know, can you string them together? Can you make a sentence? Can you pull down your pants and say that you have to go to the bathroom? Like that's what matters. And I think that that's where we need to be, is not to continue to say like, let's add another site, add another site. I think it's great because the more sites, the more impact, but we really need health systems to say, let's adopt this. State departments of health, right? And so, but everybody that's doing implicit at a site is part of a health system, is part of a state, is part of an organization where we can leverage what we have to say, let's do this at a more macro level for people that have more funding. So we knew that this grant was going to end in 2025. And when this grant started, I definitely had black hair, for sure, had black hair. And as we got closer to the fact that like this grant was going to end and the funding would stop, and everybody's job was sort of at stake, like, you know, we sort of got into like, this is the challenge with grant funded work. And, you know, I think we had to be strategic. One of the ways that we were strategic is to think about hiring positions into organizations that would allow those positions to continue if the grant funded ended. And so we have positions through academic departments, you know, through University of Pittsburgh, through Lancaster General Research Institute, and through Penn Medicine's Department of Family Medicine and Community Health, where that staff can be hired and still supported, you know, and maintained even if grant funds sort of change or end, you know. And so that's an important piece of that network. And we were unfortunate to lose, you know, our funding currently just didn't include UPMC or Pittsburgh. And so we didn't have any funding for the position that we lost recently in Western Pennsylvania. But like that's an important piece of how we expand and think about how we staff for the future. We have encouraged other states to reach out to their departments of health, because there's no reason why Pennsylvania has to be sort of the keystone state. It is the keystone state, but it doesn't have to be the keystone state for the implicit network. That funding can exist in any other state and still support the network that we're doing. And even though Pennsylvania has had 2 rounds of funding, you know, other states have got 0 rounds of funding. So it would be a novel idea and the first time funding in those places as well. We did ask for a continuation from Pennsylvania. We said, listen, we're doing great work. We meet all of the milestones. You love us. You know, we turn everything in on time. Like, this is great. And, you know, we have lots of more work to do. And you guys, you know, like it aligns. And that was denied. And so we've done the thing that we've relied on for success in the past, which is to write grants and write grants and write grants. And most of them are not going to hit. But if you write enough, you're going to hit. And so Stacy, I don't see where Stacy is, but, you know, Stacy connected implicit with her like NIH research colleagues at Pitt, and like in a last minute, you know, Hail Mary, the NIH decided to fund a couple more programs, and they liked the Pittsburgh program, but the part that they liked about Pittsburgh program was the implicit and ICC model. They thought that was really innovative. So for the first time, I think, you know, the NIH has funding directly to a university that is supporting interconception care work and the work that we're doing. And so, you know, NIH budgets are much bigger, and their work is focused on Allegheny County, but it's really important that was recognized in that way. And that's a 7-year, 6 or 7 year sort of mechanism that's, you know, is pretty significant in terms of, you know, where it stands in maternal health. At Penn, we asked the state to apply for the HRSA State Maternal Health Innovation Grant, and they said no. And I asked again, and they said no. And then I asked another, you know, organization that they work with, and said, how do we get the state to go? And we just said, we're just going to start writing the grant ourselves and say, like, you know, we're going to move forward. And we did. And the state said, okay, we're in it. And so we wrote a state maternal health innovation grant because Pennsylvania had never had one, and we got it. And so we proposed to use that funding to support the implicit network, and we did. The UPMC Western PA was looking for funding to support the position and applied to a couple of foundations that you saw. We were successful in getting one at Shadyside. Unfortunately, it was like 2 months after like that position terminated. So the goal was to sort of keep somebody in that position for another year. But now we do have the opportunity to bring somebody on to support UPMC in Western PA. And then the FMEC, sort of slid in with Emily Long's support and wrote a grant to the Philadelphia Department of Public Health that most of the sort of larger institutions were not able to get. You needed to be sort of a smaller nonprofit institution with a smaller budget, and FMEC qualified. And so we got a grant from the Philadelphia Department of Public Health to expand the implicit network to the other family medicine residencies in Philly, for which there are a total of 7, 6 other than Penn. And so we're working with 3 or 4 of those, as well as a children's hospital pediatric residency program to come on board into the implicit network. So I want to talk about what's next. This is, you've maybe heard this or seen this mentioned before, but prior to this round of funding, I think 35 states in the U.S. have had a HRSA Maternal Health Innovation Grant. The first awards were done in 2019. Pennsylvania applied and didn't get one, including sort of a collaboration with the Implicit Network, and then didn't apply again until this most recent round. And so these grants, they're either $1 million, $1.5 million, or $2 million, depending on the size of the population. And so for Pennsylvania, the number of the size of the population, number of births, is we qualify for $1.5 million. So this is money that just started coming into Pennsylvania. It's a 5-year grant. It's a collaboration between the state government and HRSA. And really the goal of these grants are to take the state maternal mortality review committee and to build a maternal health task force, and then to build a pathway to implement the recommendations of MMRCs. And that's really, sort of the evolution of sort of what there's MMRCs, there were none, and now there's a lot, and they make recommendations, but the recommendations sort of go nowhere. And so this sort of mechanism is like, how do you have a task force that sort of can, track what's going on in the state and take those recommendations and implement them and, and get better outcomes. And so we were already working with the state. Implicit had been working with Pennsylvania Department of Health for 9 years. They liked us. The same people that administer our grant were the same ones that are doing this, and so it was easy to sort of make the connection to say we're already in the state. In fact, we're one of only 2 statewide collaboratives around maternal health. That are focused on maternal health. And so we're a known entity already. And so this money, not all that money is ours, but that, but a chunk of that, a third of that money will come to support our team to do both evaluation and implementation. And so the evaluation has sort of a lot of other components that may not be entirely related to implicit, but for the implicit sites. And if you are a Pennsylvania implicit site, pay attention, because we're forewarning you that we're coming after you with 2 requests in the next month. One is going to be a survey to the site directors that asks about sort of what it is that you do with implicit and those types of things at your site, and a variety of factors to understand, well, what are the other resources that you have available that have allowed you to have either the success or not success or challenges implementing models of care like implicit ICC or implicit 4th trimester. And then we're going to follow that up with a structured interview that's about an hour long from the Mixed Methods Research Lab at Penn that really asks about, sort of what engagement you have with the implicit network, what are the barriers to sort of being able to sort of participate in those things, what are the challenges with buy-in, or, the sort of facilitators of buy-in that allow you to sort of be either successful with any pieces of the ICC model or pieces of the 4th trimester model. And what we're doing is sort of a complicated analysis that is called a qualitative comparative analysis. A QCA takes all of these inputs and it finds, like, how like water sort of like, finds its way through like the lowest, sort of pathway, and it can sort of make its little channel to, get to someplace lower. There's a lot of different ways for sites to take a model and to be effective at it. Sometimes you have, well, all of the faculty are involved, or you have all of the resources, or you don't have any of the resources, but you have a lot of passion, or you have, you don't have any resources, but it's built into your EHR, or you don't have an EHR, but you have really good stone tablets or something like, so there's like a million different permutations that are possible. And some of them result in you being able to implement new programs and to be successful, and some don't. So what a QCA does is try to figure out where is the bottleneck. What is the key piece that you need to have? And if you don't have that, you're not going to be able to implement implicit, or if it's not implicit, it's an AIM bundle. And if it's not an AIM bundle, it's the new recommendation from the state, or maternal blood pressure screening at, newborn visits, or whatever the innovation is. It doesn't matter. If you don't have those pieces, like, it can't be successful, because we can keep on making recommendations at a state level to primary care, to OBGYN, to pediatrics, to hospitals. That's what happens now. And they're only marginally effective, and so we're trying to understand how we actually do better implementation. And that's sort of the goal of what this is all about. And then our implementation team, which is really the sort of pseudonym for implicit, is going to work with the target communities that will receive awards from the Jewish Healthcare Foundation in Pennsylvania to improve maternal health in those communities. And not everybody's going to be a family medicine residency for sure. Not everybody's going to be ready to implement an ICC model, like, I'm just going to dive in and do all implicit ICC. They may not even do pediatric care. They may not do obstetrical care. They may not be able to do fourth trimester, but they should be able to screen for intimate partner violence. And they need to be able to recognize birth trauma, and they should be able to sort of, make, access to contraception for people who need those, or to understand what happens when somebody screens positive for depression, all the things that implicit already does and knows how to do well. So we've taken all of the things that are part of our model, and we've deconstructed them all into various little pieces. And we're going to then use those pieces to say, well, what would work in this site, and what can you do to improve maternal health? And then we'll work with sort of the ongoing networks like the PCMH and the Perinatal Quality Collaborative to sort of, help do some workforce development around the things that we do with implicit. So I just want to end there to say, we started with somebody connecting us to the state government. We ran a cycle for 9 years of funding, and at the end of that, knowing that grant was going to end and our sort of that relationship was going to terminate, we were able to sort of partner with the state to get federal funding, which is more than we've had before, and will support our team indefinitely into the future, at least for the next 3 to 5 years. And these are sort of, I think, the models that we need to do at other sites to continue to grow implicit, not just in terms of the number of sites and the number of states, but also in the sort of the quality of the work that we're doing and the dimensions in which we're improving care. So thanks for letting me be here today. And before I turn it over to Anna Federoff for the closing remarks, I just want to say that none of this would be possible without the work of everybody over here. And so they came, they've been here since Tuesday, and they've been preparing for weeks to get ready for today. We just sort of show up and hear how wonderful implicit is and, get some new ideas, but they really bring all of this to what we do for the network each and every day. And so I just want to take a second to recognize you guys for making this a successful meeting. Yeah. They also lugged all of that shit over there, all the way from Pennsylvania. So, and none of that should be coming home with us. So make sure you get your swag. We should be proud of Implicit. We should be proud of our logo. Drink that water cup on every meeting. Let people ask you what Implicit does, and be proud of what you say after that. So take that stuff and wear it proudly. Thanks.
So before we do closing remarks real quick, because I know we have some people who are doing the also course, which needs a lead, I would like to get a group photo. So if everyone could make their way up to this corner, and then we'll I'm bringing her to that one, take her picture. Yeah.
I was just gonna say, yes.
But
Brad, you really gonna do the wrong thing. I can see you want to actually stand up. So you have to stop it. I don't think it's. That's what it- Really, you have. See all of you, you're good. Let's stay out. All of you, you have good, everybody's good. Okay. There you go.
All right, so then we're gonna do some closing remarks. Thank you for humoring us. If you leave them there, we'll get them. All right, so as people are getting some swag and getting back to their seats, so just a couple things. One thing is with this new website, we would really like to update our implicit video. Currently on the website is the old implicit video, which was also on FMEC's website. It is, I believe, Jess is in the video, which was many years ago, so we would like to update it. And one of the things we really want to add to it is some testimonials from the people who are part of the network, so kind of the whys. So if you're able to stay for, it probably will not be 15 minutes, but like 5-10 minutes after this meeting and are willing to be videotaped for a short, like telling us why you're part of the network, that would be amazing. If you can do that, just stay after and come see us and we'll get it done as quick as possible. Not going to belabor this. You all have this on your table. This is really highlighting the implicit presentations and posters that are happening at FMEC this weekend, but also just highlighting our network members and what they're doing at FMEC. So even if it's not specifically implicit related, please take a moment if you're able to support them in their work. So just some upcoming events. So webinars, like I said, be on the lookout for that. We're currently working to schedule and secure presenters for that. So once we have that, we'll be sending out dates for that. And again, a reminder, we will now be having CME credit available for it. So hoping that this increases ability for participation. Our spring meeting will be Friday, March 13th, so put that on your calendars. Right now, the time frame is 8 a.m. to 12 p.m. The only way that could possibly change is maybe bumping an hour back. We're just logistically, as we continue to grow as a network, we're getting into new time zones. So we do have some in the central time zone, but we also with some potential new sites like California. If they're interested in attending, trying to not make it 4 in the morning for them or 5 in the morning. But yeah, so please put that on your calendar. I'll send out a calendar invite after this meeting as well. Please don't forget to register for the new website for the members only section. That really will be a resource that you can get workflows, IRBs, all of that, and also just utilize the website. If you do not see anything on the website that you would like to see, please let us know and we'll get it added. We still have some stuff we're working on. We really wanted to just get it launched and out there. So some of the member specific stuff is a little bit behind on getting that. And then also follow us on Instagram. That we're trying really hard to have more of a presence and to get the Implicit name out there and known. So that is great. We always love to see when a new resident training happens and we suddenly get a bunch more people joining our Instagram, following us on Instagram. So would love to see more of that. And lastly, thank you very much, everyone. I know it's definitely a big ask for you to come in early to the meeting, and some of you are coming from sites that are not associated with FMEC. So we really appreciate you coming and attending the meeting. It means a lot to us, and we really are able to use this meeting and the energy from it to really set the course for the next year and what all we're doing. So thank you very much for everything.